Rhinoplasty.
5, 4, 3, 2, 1. You are live, sir.
Thank you, Dinesh. So, good afternoon, everyone. We welcome you for this rhinoplasty cadaveric dissection demonstration. And it's a great pleasure to have some legends with us. And the biggest of all, I call him as a global teacher, Dr. Santadeep Pon from London. You
Thank you,
know, the
Satish.
kind of teacher he is a different soul, I would say. He is a celebrity rhinoplasty surgeon in London. He is a teacher par excellence. He has been, visiting Jaipur. He has been so kind on a request for sole teaching, hands-on teaching program in rhinoplasty, one of its own kind in the world. You can say there has been, you can search nowhere in the world this kind of program going on, and we are grateful to him for all these the time he spares to teach the students. And he is currently the president of European Board of Certification in Facial Plastic and Reconstructive Surgery, who decide who is eligible to propagate the knowledge of facial plastic surgery. And that is, I can believe, is the toughest job one can believe. And he has been kind enough to join us, sparing his valuable time in spite of his busy schedule today. Thank you, Dr. Santadeep, for being with us.
It's always a pleasure, Satish.
Thank you. Your comments are always valuable. You can, the Dr. Sunil Tawar, who is dissecting today, is his beloved students. And Sunil has been organizing all events with Dr. Santadeep in Jaipur, wherein a lot of doctors have been benefited so far. And it's a pride moment for Sandeep as well. He's a student demonstrating today. So, Dr. Sandeep, your comments are valuable. Every single comment of you is a dictum for us. Is the kind of knowledge and the experience you have in rhinoplasty and facial plastic is unbelievable. Thank you for being with us. And I can
Pleasure.
see on screen my brother, Dr. Ashim Desai. You have seen him in our previous webinars as a otologist. Believe me, he's a versatile surgeon. Otology obviously is baby. Beside this, he's a fantastic rhinoplasty, sleep apnea surgeon, endoscopic sinus surgery, skull base, lateral skull base. He has been part of the Fish Foundation for the lateral skull base surgery, and lot many things. Thank you, Dr. Ashim.
You are
for
too
being with
kind,
us.
brother. You are too kind.
And thank you for
can
joining
learn from
us
you.
on such a short notice. Thank you. Feel free to interrupt us anytime.
Absolutely.
Dr. Sandeep Ashim has been, we have been so grateful to him for coming to Jaipur so many times for teaching us rhinoplasty, besides the otology surgery, and operating on very, very, super private VIP cases of us in rhinoplasty. Thank you, Dr. Ashim.
I'm honored to be in his presence.
I am
And you
honored
know
too,
what
brother.
Ashim is. Sandeep, you know what Ashim is.
Yes, I do.
Thank you.
Amazing.
And now the greatest moment for me today to introduce someone. This young chap, the young professor of plastic surgery, I can bet anybody who can guess what he is. How old he is. He has been my teacher since my residency. He's a 62-year-old professor of plastic surgery, ex-head of department, SMS Medical College. And what a versatile surgeon he is. Yes. But he's not. He doesn't look like. Dr. Sandeep, besides rhinoplasty and so many flaps and all, he's the one who has been doing so many free flaps for us and so many. Any XYZ thing you expect from him and you get it. Simple. Now, like in our oncology resection, what XYZ bastard thing we do, nonsense thing we do, and he'll reconstruct. He give us so much of liberty to do anything, and he'll end up doing a fantastic reconstruction.
The problem is, Satish, he looks like my resident. I mean, he, honestly, he looks young enough to be my resident.
Amazing person he is. And still, even the residents do not work after the shift. but he's the one who has been working almost 18 hours a day. Still, I'm not talking 20 years back, but still the same schedule. Even if shift is over, the hospital time is on, he would keep operating in the emergency for poor fellows. Thank you, sir. And it is under his, chairmanship we are organizing this event. Thank you. And the man of the match, Sunil, is going to demonstrate. And I wish this is going to be a fantastic, informative event. Sunil, we all know, is a dedicated rhinoplasty surgeon. I'm so privileged to have Sunil, who has worked with us previously, who is fantastic otologist, endoscopic sinus surgeon, and now he is par excellence rhinoplasty surgeon. And the biggest credit goes to Dr. Santadeep Pond.
Yeah.
Thank you, and thank you, Sunil. Now we start off our program. Besides Sunil, his wife has been a big support to him, who is the leading, believe my words, she's the leading laparoscopic gynecologist in the country. In the entire nation, she has been teaching so many gynecologists the laparoscopic surgery, organizing teaching courses all across, everywhere. We are proud of her. So Sunil, go ahead with the...
So thank you. Good afternoon, everyone. First of all, I welcome all of you in this Global Rhinoplasty Update webinar. So we are going to demonstrate this cadaver dissection demonstration. First, we discuss that the why in all aesthetic surgery, the rhinoplasty surgery is the so difficult or challenging surgery. So there are certain important factors. There are certain factors that make this rhinoplasty surgery a challenging surgery. The first challenging factor, the nose have the great anatomical variations. So the nose, the anatomical variations that make the rhinoplasty is a challenging surgery. The second important that make the rhinoplasty surgery is more challenging, and this is the surgery. In this surgery, the surgery need the form and the function. In the other surgery, there is no need of the functions, but in this rhinoplasty surgery, we need the form and the function. The patient should be happy for the functional and the cosmetic issue. And the third important factor that make the rhinoplasty difficult, that is you do the surgery, but your result match with your patient expectations. So when you do the surgery, then by the second person expectations, you meet the results. So these factors, they make more complicated in all aesthetic surgery, the rhinoplasty surgery. So there are some...
Can I ask you one thing before you start? Can you show us the surface landmarks relevant to rhinoplasty?
Yeah, definitely. So there are certain basic important step for the a successful rhinoplasty. The first important step, that is the selection of the correct patient. You are a good rhinoplasty surgeon, your skills is very good, but if your selection of the patient is not good, then it's very difficult to satisfy the patient. So your patient always that is primarily motivated, not secondary motivated, and after the patient. And the first step, the comfort zone of the surgeon. Whenever you do the surgery, like a beginning for my especially advice for my junior colleagues, then if you do a case in your beginning time, then a easy case like a hump nose or simple, and if your patient is happy, then you send another patient and you also happy, then you increase your. But in the beginning phase, if you do a complicated case and the result are not good and the patient create the nuisance, then on the surgeon confidence. So the important thing, the comfort on surgeon is also important. Second important, that is patient and by the endoscopic, you should assess the turbinate conditions, the internal sapler deflections. So the preoperative analysis is the foundation of successful rhinoplasty. And the third important step, that is the thorough background knowledge of the nasal anatomy, nasal dynamics, and the nasal aesthetics. For correction of the abnormal anatomy, always you know otherwise you cannot correct the abnormal anatomy. And patient have the normal anatomy, but what is the normal parameters? So you always analyze the aesthetic analysis of this nose and what dynamic factor that control this anatomy. So these all things are necessary to make a pre-operative plan that patient what deformity underlying the skin. So these are the factor for a successful rhinoplasty. For understanding of the nasal anatomy, this entire nose pyramid we can divide in the two component. One is the outer component. Outer component that consists this soft tissue envelope and its associated landmark. And the second component is the inner framework under this soft tissue envelope. So the second component, again, we can divide in the three parts, that is the upper third, that is the mid third, and that the lower third. So there are the most important thing. First, we discuss the important landmark regarding the bony pyramid. So the first landmark regarding the bony pyramid, that is the glabella. Glabella is the most prominent part on the forehead, and we can appreciate in more in the profile view. So if important muscles from the glabella, the skin arise, that is the procerus. So the procerus muscles arise from the glabella and inside from the lower part of the nasal bone. So
Sunil,
yeah.
Can you enumerate all the surface landmarks first?
Yeah.
So that we can understand.
So this is the glabella that in the
hand is coming in between. Yes. Now.
You just focus it.
Yeah.
So this glabella is the most prominent part in the midline. So a very important aesthetic angle, frontal angle, we measure from the glabella to the nasion, and we also measure the length of the forehead also in the aesthetic surgery from the glabella. Then the second important landmark, that radix. So radix is the frontal nasal suture. So basically radix is the root of the nose and the starting point of the nose. So the deepest point in this frontal nasal suture, nasion usually fall on the supratarsal fold, and this is the upper for the transfer. And then,
so we are not supposed to go in osteotomy about this.
Yeah, this is the important landmark for the transverse osteotomy. Never go above the nasion.
Dr. Santadeep. Hello?
Hi.
Can I ask you one thing?
Yes, of course.
If somebody goes in osteotomy, why from low to above, and happens to go through the frontal bone above this, what Sunil mentioned is landmark.
Yeah.
What can happen?
So first of all, it's very thick bone, so it's actually really quite difficult to do that. But if there is, if you go through that,
how to know what is the end point?
Well, you have to mark your end point. When you're first starting, you have to look for the glabella and know where your end point is. So it's pretty much where Sunil has marked it. Between really, what I tend to use is the lowest most point, and in between the medial canthi is roughly where you're going to aim towards. But you have to be able to judge this and not go too far. There's two things that can happen. First of all, if you go into that very thick bone, you can end up with what's called a rocker deformity, where part of the bone moves. I mean, it's difficult to show that without being there, but you can end up with this thing where the bone doesn't go properly, doesn't mobilize properly, and it's what's called a rocker deformity. But there has been reports of CSF leaks following rhinoplasty surgery. It's something I have never seen in my practice or ever experienced, but it has been reported. And in fact,
so your feel and experience matters.
Your feeling experience definitely matters. And in fact, there is one, I have a picture one of my colleagues saw of a patient who ended up with a encephalocele following a rhinoplasty, believe it or not. Unbelievable. So you can go higher.
Can I ask, once you're using chisel, does the sound change when you go to the frontal bone?
Yes, of course. So what happens is that you, when you're low down, and I'm sure Sunil will show this later on, when you're low down on the maxillary bone, i.e. on the frontal process of the maxilla, it's thick bone. And then when you come back up again, you're into thin bone, which is the nasal bone. So don't forget, your lateral wall consists of the nasal bones, which are the most super. Sunil, show where the nasal bones end and the frontal process of the maxilla is. Just put a landmark there, Sunil.
Great.
Can you see that, Sunil?
Yes, sir.
Yes.
So just show approximately where the nasal bones are and the frontal process of the maxilla, so that people understand that the lateral wall isn't just the nasal bone, it's actually the frontal process of the maxilla. And the frontal process of the maxilla is thick, so it's a much heavier sound when you're fracturing through it, whereas when you're in the nasal bone, it's much thinner. And so if you're going into the frontal bone, it will start getting thick again. But it's actually, thankfully, quite difficult to do because it's much thicker bone. So by the time you in the nasal bone, you fracture, it fractures very easily. So it's very difficult, but experience, of course.
Yes.
So the next important landmark regarding this bony pyramid, that is the rhinion. So basically the rhinion is a cartilaginous junctions, because the upper 1/3 the nose, that is the purely bony, and the lower 2/3 that is the cartilaginous. So this soft tissue correlation regarding this junction, that is the rhinion, and the bony point regarding this, the cilion. So there is two important thing regarding this rhinion.
Rhinion and cilion.
Yeah, rhinion and cilion. So this soft tissue point, that is the rhinion, but below bony that is the cilion. So there is two important things regarding this rhinion. First, a very important area, that is the keystone area below this rhinion. So keystone area is the confluence of the nasal bone and the upper lateral and the perpendicular plate of the ethmoid and the septal cartilage, quadriangular septal cartilage. So yeah, it's an important junction. So in this rhinion area, this nasal bone overlap the upper lateral cartilage. So in the central rhinion area, this nasal bone overlap around the 14 millimeter, but in the lateral part is around the 5 to 6 millimeter. So this upper lateral cartilage get the maximum support from this rhinion area. So during the rhinoplasty, especially during the osteotomy, we always maintain the integrity of this area. This is my message to my especially junior colleagues, because sometimes when the patient have a crooked nose and when we go for the medial osteotomy, then at that time there is a very chance of the disruption of this rhinion area. So you always maintain the keystone area during the osteotomy. And
Sunil,
yeah,
I have seen Achim.
Yes, sir.
Can you hear me?
Absolutely.
I heard your septum lecture, nasal septum in rhinoplasty, which mesmerized me, believe me. And I know you have been removing septum sometimes like completely, sometimes partially, and you do many things with the septum.
Right.
What Sunil mentioned about this keystone area,
Yes.
do you remove the septum from that part as well in extracorporeally or some other septal removal?
Yes, it is necessary to, when the complete extracorporeal septoplasty is done, it is necessary to remove the septum completely. But one has to take a lot of pains to ensure that reconstruction is done in a very firm way, because otherwise collapse can occur. So generally what I like to do is what I call anterior septal reconstruction, which is called the MOST technique, M-O-S-T, in which we keep the keystone area intact and a small piece of cartilage attached there. and the rest of the septal cartilage is then attached to the keystone area. Sandeep, your opinion on this, please.
Oh, great.
Sorry. Yeah, I agree entirely. I mean, I think you want to maintain that keystone area wherever possible. And certainly when you're doing septoplasty surgery, one of the things where septal surgery fails, I think, is when you have a high septal deviation, and residents in particular get very scared about extending that, extending the what I call the posterior chondrotomy, so where you're detaching it off the bone and the cartilage. People get worried about doing it too far up. And you have to be careful about the keystone area, but equally you need to be within a few 4 or 5 millimeters of it and you're still okay. But the keystone area is critically important in septoplasty surgery, as Ashwin has mentioned.
Yes, sir. So the another important thing regarding the rhinion area, the skin thickness. If we compare the skin thickness on the dorsum, then the skin thickness in the rhinion area is the thinnest. So great care should be taken meanwhile when we elevating the flap, because this is the site where you have a maximum chance of the damage of the skin. So the skin thickness play a important role. If we analyze the skin thickness of this nasal pyramid, then have the skin have the epidermis and the dermis and the subcutaneous tissues. So the subcutaneous tissues have the superficial panniculus layer and the SMAS layer and the deep fatty layer and the perichondrium and the periosteum. So there is variation in the dermis layer in the entire of the nose pyramid, and in the superficial panniculus layer there is lot of adipose tissues. So the adipose tissues, they have the vertical and fibrous septa that connect with the SMAS layer. So this layer transmits the force of contraction of the SMAS on the skin. And the third layer below the SMAS, that is the deep fatty layer. So the deep fatty layer doesn't have the fibrous septa. So that facilitates the movement of SMAS on the rest of the dorsum. So that is the completely avascular layer. So that the below SMAS, that is the completely avascular plane. So that is also an important thing. Now, after the bony wall, the mid wall consists by a pair of the upper lateral cartilage, that is the spanning laterally. And the two important thing regarding this upper lateral cartilage, one is the medial margin of this upper lateral cartilage attached with the septum. So this attachment is a 10 to 15 degree angulation. So that is the internal nasal wall area. So during the rhinoplasty, we always maintain the nasal wall area, or we recreate after the hump removal or something by the spreader graft or the splay graft. And then lateral part of this upper lateral cartilage that attach with a wedge of bone on just lateral to the anterior end of the inferior beneath. That is external triangle or the Webster triangle. So we always preserve the Webster triangle also during the osteotomy, because if we damage the Webster triangle, then this lateral margin of the upper lateral cartilage is medialized and they create post-operatively nasal blockage. And another important thing, because the head of the inferior turbinate is also attached with that part. So the head of the inferior turbinate is also medialized if we damage that part. So we always preserve that part. And then after the mid vault, the lower vault. So is this lower vault, this nasal lobule, we can divide in the subunit. One is the tip lobule, and on lateral to this tip lobule, that is the ala lobule, and between the mid, this is the columella, and just medial to this columella and lateral to this columella and medial to the ala lobule. This is the entire nostril cavities. So for study, for understanding, we can divide in the different subunit this tip lobule, nasal lobule. So there is two light reflecting area. Just focus. Yeah, focus. Nice. So there is two light reflecting area on the tip lobule, because the tip lobule is the most anterior projecting part of this nasal lobule. So this two tip defining points. This light reflecting area is tip defining point. So the distance between the tip defining point is the width of the tip. And now where the tip is end and the dorsum is start, where the tip end and the dorsum is start, this is the supratip break. So this supratip break, that means this dorsum and the tip lobule, there is 1 to 2 millimeter inferior. So this ideally, this is the aesthetic pleasing appearance for especially the female patient. So this is the supratip break. And where the tip is end and the columella is start, that is the infratip break. So if we met all these points, this supratip break and the infratip break, then there is a diamond shape. So this is the diamond tip concept. So the superior half of this diamond and the inferior half of this diamond, that should be equal. Now on laterally, this LR lobule attached with the upper lip and the cheek. So this attachment, that is the nasofacial groove or facial groove. And this convexity of this LR lobule, that is the flaring of LR rim. So the convexity of this LR rim, that is the flaring of. So if you want to reduce the flaring that we do for the LR wedge excision. So this is the role of the LR. You should know which part is affected and how can you treat. Then the important thing, that is the columella. So columella that have the two part. One is, this is the foot plate of the columella, and this is the columella proper. So this foot plate of the columella basically rest on the fatty tissues, and the width of this foot plate, that is the width of the base of columella, and this is the columella part. So this is regarding the important surface landmark.
Do you want to mention something about the soft triangle?
Yeah, this is this nostril cavity. This nostril, on the apex of this nostril, there is a triangle, that is the soft triangle. In soft tissue triangle, the important thing, at that area had the devoid of the cartilage. So there is very dense skin to skin approximation. So yeah. So during the marginal incision, if there is a minor injury, then post-operative the patient develop the notching and nitrogenic deformity.
We would like to know, when you give incision there, how to protect the soft triangle. We would like to know when you give incision.
When we
when you make the incision, tell us how to prevent fibrosis incision in that area.
Yeah.
One point I wanted to make regarding the foot plates. There are a group of there are some rhinoplasty surgeons during the approximation of the septum to the columella, I mean to the lower lateral cartilages, they tend to approximate even the foot plate of the septum towards the septum, and that causes an unsightly deformity. So the point that was brought up was very important, that the foot plates of the medial crust should be allowed to remain separate for the aesthetic look.
Yeah.
Yes. Sandeep, you being in London, you are a celebrity surgeon. You must be getting so many high-class fussy patients. Pre-operatively, looking at the nose profile, how do you give them reassurance about the post-operative outcome? Do you use any software, or you believe in that software funda and all that? Or,
I do.
Or any different you do?
So I do. So my rhinoplasty consultation is I have 2 separate rhinoplasty consultations for each patient, a minimum of 2. That's the minimum. If they want to come for more, they're very welcome to come for more. And I think it's important you do that, because certainly in the UK, it is important that patients are given enough time to think about it. So on the first consultation, we look at the patient, we go through what their deformity is. I talk them through the basics of what surgery is, how we're going to do it, what I propose doing. And I go through all the risks of surgery as well in the first consultation. And then the second consultation, which we book about 2 weeks later, so give them time to go away. I direct them to my website so they can read. And then on second consultation, we have a imaging program. I actually use a 3D imaging program. So there are very cheap programs. You can even buy apps on phones now, which give you very good imaging for the profile view. But I think where I find the 3D imaging really helpful is it really shows them from the front view what the nose would look like. And let's face it, most people look at themselves from the front all the time rather than the side. So I find the 3D view very helpful. And the most important thing, if you are going to image the patient, is to be sure that they understand that, I explain it to patients saying that this is pixel manipulation as opposed to tissue manipulation, which is a very separate thing. And I think the other thing to say to them is, or the other thing to do is, don't use it as a marketing tool. By that, I mean, don't sit there and try and give them the perfect result on the screen, because then inevitably they want photographs of it. Or even if you don't want to send them, they'll take photographs of it. So I don't even bother anymore. I let them take the photographs. I never used to before, but I just do now. Everyone's got a phone, they'll take photographs of it. And if you've shown them the perfect result and you can't achieve it, they're going to be disappointed and angry. So I always underestimate and overperform rather than the other way around, because otherwise you're going to end up in trouble. But yeah, I think it's very useful as a tool.
Yes, that's a great message. Ashim.
Yeah.
You dealing with the Bollywood celebrities, how do you
I wish.
How do you deal with pressure about the expectations?
Exactly as Sandeep said, that I would much rather that give them lesser expectation and then over deliver on my promises. The biggest, and in fact, I don't use too much imaging because I tell them that it will give them a false idea of what they can achieve. And I always tell them that you cannot get somebody else's noses. When I talk to the patient, I generally discourage people who come with celebrity noses and say that I want something that looks like this or something that looks like that, because then I know that 9 times out of 10, I'm not going to be able to keep them satisfied. However, if I'm able to give them realistic expectations that, look, this is your problem, and this is what I propose to do for it.
Dr. Asim,
yes.
Dr. Asim, I think the first thing we should forget about that the patient is celebrity or something else.
Yeah.
We have to treat
every patient is exactly the same.
Yes,
Agreed.
yes.
Completely.
For everyone's information, Ashim is amongst the topmost 10 doctors in India. You can go and check Google.
Yeah.
And this is purely his dedication, his work, nothing else.
No, boss, you're too kind.
Proud of.
So
if yes, I'm number 10, I know who's number 1, and that's Satish Jain.
No, I'm nowhere close to you. Nowhere. Yes, Sunil.
So we discussed the inner framework of this nasal lobule. So the inner framework of this nasal lobule by a pair of LR cartilage. So the LR cartilage have basically the 3 parts. One is the medial most part. That is the medial crus, and another is the lateral most part, that is the lateral crus, and the part that connects these 2 parts, that is the intermediate or the middle crus. So this medial crus have the 2 parts. One is the foot plate and another is the columella. So the foot plate part is basically rests on the fatty tissue of the anterior nasal spine, but sometimes in the advancing age or due to the infection or due to the trauma or the surgery, this fatty tissue may get reabsorbed and consequently the patient develops the tip droop. And this is basically the support the rest of the tip. And another, the columella part of this medial crus is an important landmark. After raising the columella flap, this is the first part we identify for further dissection. So it's an important landmark. And the length of the columella part of this medial crus is also vary in different ethnic variations, like in the Caucasian people is a long, and in the Asian and the Black is just short. So the length of this nostril cavity is short or long, so depend on this columella part. And the second important part, that is the intermediate crust, that have the two parts. One is the domal part anteriorly, then posteriorly is the lobular
Will you
part.
show us all the three parts?
Yeah,
Yes.
yeah, we definitely show. So the lobular part is basic. The lobular part is important part, and the width and the angulation of the tip is dependent on this intermediate crust. The rest, the third important part, that is the lateral crust. So that is the widest part of the LR cartilage, and it gives maximum volume to the tip. So that have the two margin, that one is the upper margin and one is the lower margin. So upper margin of cephalic part of this lateral crust and the lower part of the upper lateral cartilage have a interlocking, that is the scroll area, and that is one of a major tip support mechanism, because the tip have the three major tip support mechanism. One is the size, shape, and resilience of this entire LR cartilage, and second is the scroll area, and third is the attachment of the caudal septum with the medial crust.
Scroll means the junction of upper and lateral.
Yeah, the lower part of the upper lateral cartilage and the upper part of the lateral crust of the LR cartilage, they have the interlocking like this. So that is the scroll area. That is the one of major
That is very
support. Yeah, that is the one of major tip support mechanism. So these are important landmark and anatomy regarding the inner framework of the nose. So now before start of the dissections, we discuss about the infiltrations, because the infiltration is an important part. So whenever the important thing, whenever you infiltrate, then always first you identify the deformity. Otherwise, the deformity is distorted due to the infiltrations. And if you mark your nose, then you mark before the infiltrations. So
very important.
We infiltrate, then we use this 5 ml syringe and the 26 gauge needle. So first we infiltrate for the transcolumnar.
This patient, don't worry about the bleeding. I'll take care of the anesthesia part. You know?
So infiltrate for the transcolumnar incisions, and
I'm giving anesthesia.
Then between the dome area, and after the infiltration, we must massage this one. So that spread between the dome area. And then...
So is it directed to some vessels to go into spasm or random?
You always eat spread. We discuss after this one, the blood supply of the nose.
Yes.
Then definitely I tell you. So
Sandeep, I remember, you keep on doing. I remember last time when you come, you describe the blood supply which you target with your infiltration. Can you enumerate in brief?
So
what vessels do you want to target to go in spasm?
So I think the main one is really the columellar vessels. That if you're doing an open approach, it's always the columellar vessels which bleed the most, and the columellar vessels which come up the columella. So it's always, as Sunil showed there, it's always worth injecting the columellar area in that region. And the other thing is, as surgeons, we're very impatient people. We tend to inject and start dissecting straight away, which in this patient is not going to make any difference. But in a real patient, you want to give yourself some time for the infiltration to work. So my advice is infiltrate them and then go and scrub, because it will give yourself some time for things to vasoconstrict. And then you're really just, I tend to inject into the columella and not so much between the domes quite as Sunil has shown. I will tend to inject around the lower lateral cartilages generally. And then as Sunil shows, it's through the intercartilaginous incision on both sides. And then using fingers. I mean, the wonderful thing here is watching Sunil doing this, because I can see lots of what I've taught him in what he's showing. So it's really heartening to see that. But what you want to do is inject into the intercartilaginous incision up on each side. I don't inject right over the dorsum, because it makes it very difficult then to judge your dorsum. So I tend to inject laterally and then massage upwards, so thereby minimizing the distortion to the dorsum. which is important at the end of operation when you're trying to judge where your dorsum is sitting.
Yes.
But Sunil, you're doing a great job. It's lovely to see.
It's important to understand this concept of vascularity.
So after the infiltration is transcolumnar incision, for the marginal incision, we infiltrate along the caudal margin of the lateral crus for the multiple sites around the 0.1 to 2 ml, and after that marginal incision we infiltrate for the septum area. So when you infiltrate, there is a belching or ballooning when you are ideally good plane. So if you properly infiltrate for the hemitransfixation or the Killian's incision area, then no need to the more infiltrate on the posterior side once you are in the normal plane. And for the osteotomy along the margin of the lateral infiltrate on both sides. So we discussed a little bit about the blood supply of the nose also. So the blood supply of the nose is come from the two artery system. One is the ophthalmic system and another is the facial artery system. So the dorsal nasal artery is the terminal branch of the ophthalmic artery that emerges from the mid part of the medial canthus and run over dorsum of the nose and then supply the upper part of the nose. And another blood supply from the facial artery system. The facial artery at this lateral angle of the mouth gives the two branches. One is the superior labial artery that run along the this upper lip, and in the base of the columella it gives some columellar branches. And another branch of this facial artery, that is the angular artery. So this angular artery at the level of the alofacial junctions gives the lateral nasal artery. So this lateral nasal artery and the branches of the columellar artery have some anastomosis at the lower margin of this lateral crus, that is the LR arcades. And some branches of these lateral nasal arteries and the dorsal nasal arteries have the subdermal plexus. So you always keep in mind about the blood supply of the nose, because this is an example of the anastomosis between the internal carotid and the external carotid, because this dorsal nasal artery, that is the artery of the ophthalmic system, that is the ultimate branch of the internal carotid artery system.
So we are supposed to preserve all these branches?
Yeah, during the filler injections, the clinical importance of this one during the filler injection, if you inject in the wrong plane, especially in the glabell area, then sometimes
Ashim, would you advocate something like Ashim?
Yeah.
Can you hear me?
Yes, I can. Tell me.
Would you advocate something like how to preserve these vessels to stay in some particular plane or something like for the beginners?
See, the whole thing is to get the SMAS out of the way, the plane between the SMAS and the supra and the perichondrium is where you're going to dissect. So the idea here...
Go underneath the SMS or go underneath the perichondrium?
No.
People going subperichondrial, preserving everything. Isn't that correct philosophy? Or going subperichondrial, preserving everything. Isn't that correct philosophy? Or
See, the perichondrium itself is supplying the cartilage with vascularity. So unless you preserve the perichondrium, there is an issue with the vascularity of the cartilage also. Sandeep, your opinion on this, but it should be
I believe Sandeep goes subperichondrial. And I know, for a novice surgeon like me, is it really easy to differentiate between the subperichondrial and supraperichondrial plane? Sandeep, can you clarify what should be the actual way?
When you are dissecting, you can choose, you can feel the perichondrium itself intact.
Okay.
So the concept actually was if you go the subperichondrial, if a patient have a thin skin patient like in the European patients, so in thinning of the skin, but in the Indian patient present in the Asian patient. If we go the subperichondrion, then the subperichondrion goes with the skin flap. So whenever you thin the flap, thick flap, then ultimately the perichondrium is lost. So ultimately you weak your LR cartilage. So later, because we because we have a thick skin, so later the force of the contraction, the cartilage is buckling and the etiogenic deformity. So it's depend on the person to person, but in the mostly the thick skin patient, I think the suprapericondial is good. And if you want to like the thick tissue, then later you can do. So
Sandeep, your quick comment.
Yeah. So I tend to go subperichondrial for most of my patients because we have thinner skin patients obviously in the UK than you. My only, I don't have an issue with going sub or supraperichondrial. The only reason I prefer subperichondrial really for my patients is the one you can do extra flat behind some smash, but more importantly,
ये तो कह रहा suprapericondial.
But I mean, I agree. I mean, I think the points raised by both Sachin and Sunil are very valid in the sense that if you go subpericondial, there is potential at least for some vascularity. Although I must admit I've never seen it.
Okay.
I know I've never seen it. So my normal dissection plane is in suprapericondial, and what I tend to do is just to get into the breath plane, I'll pour onto the cartilage and then go to the pericondial. And sometimes even leave the pericondial and put back again. But I think, this has been debated many times. I don't go flap a perichondrium to put back again. But I think, this has been debated many times. I don't really think it matters. My only advice is that if you go subperichondrial, you tend to get a little bit less bleeding because that's a very avascular plane as it is inside the septum. We all know that when you go subperichondrial in the septum, it's avascular, whereas if you leave a little supraperichondrial in the septum, it always bleeds just that bit more. So I think it's the same concept.
Okay, so the important thing regarding this blood supply during the filler injection, when we inject the filler, and sometimes if the filler in the wrong plane, then there is due to the retrograde embolization, the filler ultimately reach in the central artery of the retina. So there is a consequently the blindness develop. And in this study, there is 30 cases reported the blindness. So great care should be taken during the filler injection in the glabella or radix area, because there is due to the retrograde embolization, there is chance of the blindness. So you use all precautions like the white bore needle and thorough background knowledge of the anatomy, and these all other measures for prevention of this disaster complications. Another important thing regarding, then whenever we go for the open approach, then we made incision on the columella. So when we make the incision on the columella mid part, then we injure these columellar vessels. So now the rest of the blood supply of the tip is dependent on this lateral nasal arteries. So this is the one disadvantage, like one disadvantage of the open approach, that is the scar, and another is the we injured these columellar vessels. So the rest of the tip blood supply is dependent on the lateral nasal artery. So in the same patient, if we go for the LA wedge excision, so if your incision is more than 2 millimeter above the nasofacial groove, then you can chance of the damage of this lateral nasal arteries. So this is the important thing. So be careful during the incisions. So this is.
Now can you start with the incision?
Yeah. Now we start with the incision.
Oh, no, I can see. I can see someone.
Ashish Bhumkar, welcome.
Ashish Bhumkar on screen.
Yeah, good afternoon, sir.
Sandeep, can you hear me?
Hi,
I can hear you. I can hear. Oh, are you?
Can you see Dr. Ashish Bhumkar on screen?
Number 9.
You know, Sandeep, you are in the world of facial plastics, and he's the one who has shaken the plastic surgeons with his innovative work. He is the world authority in pinna reconstruction. More than that, he is the one who does, along with pinna, the hearing reconstruction. Not only the external aesthetics, about the hearing reconstruction, the functional part of it. And we have been, so grateful to him to have shown the live surgery for the pinna reconstruction. And this Sunday, Sandeep, spare your valuable time. Ashish has promised to show us the same stage pinna reconstruction along with the canal and trachea reconstruction along with the hearing reconstruction. All the three together, all together in one place. And so I think you met
Okay,
Ashish
this Sunday. Okay, now carry on with your nose job.
Yeah. So
I haven't met Ashish before, but I look forward to
Hi,
meeting you.
Sandeep. Hi.
Hi.
Ashish, today Sunil is going to show the rib harvest, the congal cartilage harvest.
Yeah.
We would like to know your comment. You have been harvesting rib in a different way
Yeah.
for different indication.
Sure.
But we all want to know about the intricacies of rib harvesting, about preventing complication, about preventing, long-term effects, and how to optimize the proper rib harvesting. We would like to know your
Sure.
comments.
Sure.
So before we go to the incision, there is some important term also you have to know that one is the incision, another is the approach, and another is the technique. So there is three important terms. The incision, that means the incision is a surgically created cut to gain access to the underlying framework. And the approach is a specific type of anatomical dissection for the exposure, like open approach, either the closed approach, like the retrograde approach. So this is the difference between the incision and approach. And one is the technique. Technique is a particularly maneuver to change, like cephalic trimming to reduce the volume of the tip, or like flip-flop technique. So these are the different terms. So you should know. And other important term, one is the primary case, another is a secondary case, and one is a revision case. So primary case, that case have no history of surgery. That we first time operate, that is the primary case. And one is the secondary case, that means a case that operated earlier by one time. And the revision case, that is a case that's operated by the same surgeon before. So these are the important terms then you should know. Now, for the open approach, we use the two types of the incision. One is the marginal incision and another is the transcolumnar incision.
How do you start from where?
So the first important thing, there are the different type of the, actually, if you go for the transcolumnar incision or the marginal incision, this is not a.
No, but how do you go in your practice?
In my practice, I usually go for the open approach.
No, open means which incision first?
I usually first the transcolumnar incision.
Okay.
There is no specific reason for that. Either you go for the transcolumnar first or the marginal. It's the surgeon's choice.
Experience, I have seen Virendra Gaisas start with the marginal. I have seen Sandeep. He is happy with any incision.
No, Dr. Foda also
do blindfolded
the marginal incision first and then transcolumnar incision. So Ashim, quickly.
Can you tell quickly for the juniors any advantage or disadvantage of any particular incision to go ahead with first, the marginal or columnar?
See, for me, I take
in brief, what is the advantage or disadvantage?
No, I like to take the marginal incision exactly at the junction of the skin and the hair bearing and the non-hair bearing skin. What happens here is that using the back of your blade, you need to identify the lower end of the lower lateral caudal end. And so once you take that incision, you can follow it downwards. And it doesn't really matter whether you take the columella incision first or the marginal incision first. But the idea is that the columella incision should either be in an inverted V or a stair-step fashion. The idea being that it should not be in a straight line because you want to avoid the problem of scar contracture. So it doesn't really matter whether you take marginal first or columella first, but the idea is to avoid the stair step, to avoid the contracture, so you don't have a straight incision. And the second thing is that you should avoid taking a too low an incision where the foot plates also come into play. So it should be just above the foot plates. So at the junction of the mid third and the lower third is typically where I would take my, of the columella is where I would take my incision. Sandeep, any other differences?
No, agree entirely. I mean, I tend to do it, I suspect Sunil does it the way I taught him to do it, which is going from medial to laterally. I think often people who have done a lot of endonasal rhinoplasty and are comfortable doing marginal incisions will tend to do their marginal incision first and then bring it down and then do a transcolumellar incision. I learned to do it both ways, but I find this an easier way to do it. But I mean, I don't think it really matters whichever way you do it. The point being is you have bilateral marginal incisions, then you have a transcolumellar incision, and whether you do it one way or the other doesn't matter. I think what Sunil will show now, is that you make your transcolumellar incision. The most important incision actually is what Sunil is making now, which is going to so he's doing marginal incisions, but I tend to do the vestibular incision first and then follow it round. So he's doing it a slightly different way. Everyone, you know, it all depends which way you feel comfortable doing. So he's doing the marginal incision as you see now. As Ashim said, it's normally in the junction of the hair-bearing and non-hair-bearing skin laterally. And then you can follow that round over the dome. I think there's two critical areas, really. One is the columella area where you've got to be careful that you don't injure the underlying medial crurae. And secondly, just coming around this corner here, as Sunil is showing here, because it's very easy to go into the dome area and cut through the dome area. I've seen that happen many times with other surgeons and my residents and etc. So you have to be careful. And in fact, this is why I prefer doing it going from medial to laterally. But I'm sure Sunil, you'll demonstrate this, I'm sure.
Sandeep, actually this question doesn't stand for you. What I meant to ask is whether this incision, whether going from the columella or marginal, has any bearing on preservation of the soft triangle, number one. Number two, any tips for the junior colleagues to prevent entry into the soft triangle?
Yeah, so I mean, I don't think it matters which way you do this, but the most important thing is you follow the margin of the lower lateral crus. And that may sound obvious and easy, but it's not easy. Meaning it's very easy to come out of the correct plane and end up into soft tissue. So you know, in the books, you'll read about using rim incisions, etc. I don't see any need ever to do a rim incision. But the most important thing, whether you do it from lateral to medial or medial to lateral, is you follow the edge of that of the lateral crus from the medial to lateral and not go into any soft tissue. So this just becomes an experience thing where you have to be sure you are following exactly the edge, because if you stray from the edge, this is where you end up into the soft tissue triangle, etc. But I think, look, Sunil is showing exactly the way I do it. So as he's showing here, we find the medial cruri on each side, and then you follow that medial crus around into the dome region, and with little snips to begin with, you just separate little snips, and this is the soft tissue triangle area. So this is, as you're coming around this corner here, you've got to be critically careful that you're not cutting, number one, cutting through the dome, and number two, you're sticking to the margin of the lower lateral cartilage coming around. And Sunil is showing this beautifully. Well done, Sunil. That's a lovely dissection where you're showing exactly what you do. Now, in many ways, sometimes it's even easier on a real human being, because you can see these cartilages being avascular planes, whereas here, of course, it's a bit more difficult to differentiate between the tissues. But it's critically important, just as you come around this edge, as he's doing here, And if you're right-handed, it's actually more difficult on the patient's right-hand side. This is often where people get stuck. So as Sunil is doing, you curve that suture round, which he's showing there, and then just follow it all the way around. So it's a lovely demonstration, Sunil. Well done.
So the idea is to follow the cartilage and not the skin. When they say
Correct.
rim incision, the problem with the rim incision is that it can cause contracture. So the idea is to follow the cartilage as it goes. Sometimes it's closer, sometimes it's further from the lower end of the skin, but you follow the cartilage. You stick to the cartilage.
That is what we have been observing. That what Sunil is doing. He's just following the cartilage.
Yeah.
You know,
So
I've seen Sandeep do a couple of cases, and he's doing exactly what Sandeep does. So
yeah. So Sunil is showing that beautifully, and remembering that the lower lateral cartilage doesn't just go laterally; it starts going superiorly and laterally. So people often think the lower lateral cartilage is going completely just laterally. It's not. There is a supralateral component to it. So as you go further and further away laterally, it's beginning to edge more cephalically. So as you come around this edge here, the critical thing here is to follow that edge, because otherwise you'll end up in that soft tissue triangle, and as Sunil has already said, that can cause contracture.
One more point I want to draw the attention of the onlookers is you can see the lower end of the incision being tensed up. It's very important to have tension at the lower end of the incision so that the plane is more easily followed. You can see the skin hook at the lower end, and that's tensing the entire incision.
Ashim, I have some people taking incision in the middle of the height of the columella, some people taking below, up. What is your message? Quickly.
Message here is that you need to have the shadow of the columella hiding your incision. So you have to figure out where exactly the shadow of the columella comes, and that's a little bit difficult sometimes when there's a columella hang. So in such a case, I would recommend that you go just above the foot plate area. Where there's a large columella hang, you're not very sure where it would fall into place. You go just above the foot plate area. But typically, it's at the junction of the middle and the lower third of the columella. So it's lower down, not at the center of the columella. Dr. Koel, I'm sure you'll agree with me.
The best. Okay.
So the important thing, there is a different type of the incision, like the inverted gullwing incision, stair step incision, or the W incision. So this is my message to my junior colleague. The type of the incision doesn't matter. The incision is in zigzag manner, not is straight, because the incision, when is the incision in zigzag manner, then there is a less chance of the contractions and less appear and more aesthetically. So the type of the incision is not important thing. The important thing is the site of your incision. Like Dr. Asim said, the site of the incision is most important. Your incision site, that should be always above the foot plate, because that is one of the major tip support mechanisms. And in the mid part of the columella, because the mid part of the columella, the medial crust have the more approximated with the skin, so the latter they have the less chance of the scar formations. So the site of the incision is most important. Sometimes if you want to deproject your nose, then your incision is in high columella, so after settle down the deprojected nose, they ultimately come in the midline. Or sometimes if you have a case of the binder syndrome, or you need a lot of augmentations, then your incision is in the low columella incision, that is the V-shape incision. So when you close it, then V to Y closure. This is a common problem. There is so many, my junior colleagues ask that whenever we need a lot of augmentation after the transcolumella flap is short. So for that, the incision is in the low columella V type, and we close it the Y, V to Y closure. So the site of the incision is most important thing rather than the type of incision, or it's your personal choice and how your boss are going, then you do either the marginal incision or the transcolumella first. Double look. So after that, your transcolumella incision. It's a very good technique by Dr. Pawn that you hold the seizure by a pen holding positions and you identify the margin of the medial crust on the both sides like in this manner. So you have the minimum chance of the injury of the medial crust. And sometimes if there is minor injury in the medial crust, then never panic, because in the beginning the complication is happened. And after that, once you go for the upward dissections, then you use a 3-point traction technique. In 3-point traction technique, you hold this flap by a 2 big needle holder, and another by your assistant, 2 by your assistant. One hold this one, and ek upar laga, ek upar laga. So this is the 3-point traction technique. And always give the counter traction, because in the living patient there is a patient have the bleed. So the counter traction is important. You always counter traction, and first you finish the marginal incisions. Never jump superiorly. Okay, and the direction of your seizure is not like this. Is like this, and you, Dr. Pon always said that you press this by the prong of this seizure, and first complete the marginal incisions. And it's an important thing that so many times the my junior colleagues ask that what is the lateral limit of the exposure. So like in the any surgery, the exposure is the important thing. So your lateral limit, you should at least expose the 2/3 of the LR cartilage. So that is good for better. Okay, upper lateral cartilage, lower lateral cartilage. Now, once after the finish, double look laga yahan pe. So this is the way by which you can here. Now,
What plane is this now? Subpericondyal or suprapericondyal?
yeah, this is the suprapericondyal plane. This is the suprapericondyal plane.
You know, Satish, to answer your question, even in the suprapericondyal plane, if you are just above the pericondium, it is quite avascular.
Yeah. So,
What? Can I ask? Is there any harm in going subpericondyal?
Like I said, you know, my discussion for ossiculoplasty holds true here, that I personally feel that Indians typically have slightly weaker cartilages, and the chances of the
Really? But
avascular
you always say,
बीच में रखे इसको ना.
you always say at least if one side is intact, it works.
I always say both sides, buddy. In n number of
least one side,
otology
at least one
conferences, I
side
said
intact.
both
This one.
sides.
नहीं नहीं यही.
So if you go subpericondyal, is it going to go necrose or?
No, not necrose. I'm just concerned about weakening. You see, Indians have very thick subcutaneous skin and slightly weaker cartilage. I'm not concerned about necrosis at all, because one side is intact. Certainly not. But we are only concerned with the weakening
Cartilage आ गया फिर तो.
and the thinning up. It's my personal viewpoint. I've had in the early part of my career, I used to go every case I used to go subpericondium, and I found that the cartilages were not giving the support that I wanted. So then I changed over, and I seem to be happier. But you know, it doesn't really matter. As long as you have the plane right, you should not have a problem.
Sandeep, in brief. Sandeep, can you hear me?
Of course, he can hear you.
I can't see him.
He's on a phone. He's on the phone.
So I cut the pitangui ligament. Pitangui ligament is one of minor support mechanism of the tip that bind the both side of the dome and with the soft tissue envelope.
Can you put a pointer on the Pitangui ligament? And how do you identify it while you're cutting through it?
Because this pitangui ligament bind the both side of the dome and with the soft tissue envelope, supratip area. So there are so many surgeons that they preserve this pitangui ligament or they repair it. But what is your opinion, Dr. Asim Desai sir?
Honestly, I don't think it really matters.
Yeah.
I personally, I don't know what Sandeep thinks, but I don't think it really matters.
Ultimately, it's to be divided.
Yeah. So,
see, ultimately, when you're having a gross deformity, you will have to divide it. So doing jugglery around it will cause later edema. Rather than create more edema, it's better to divide the ligament sharp and take care of it.
Santadeep, we want to know, Dr. Santadeep, can you hear me?
Yeah, I'm hearing
Satish
you.
is not going to leave you. Remember that.
Quickly,
I apologize, Satish. I'm in the middle of a clinic as well, so trying to sort things out at the same time.
Hello. Can you tell us in brief about the subpericondial plane or suprapericondial plane again? You have already spoken. And secondly, the kind of lateral exposure in this elevation. How much lateral exposure is required? Is it different in different, situations, or you go ahead with at least a definite lateral limit?
And finally, the importance of the Pechengui's ligament.
Yeah, okay, so three separate things. I think the subpericondial, suprapericondial decision, I think we've already discussed, and I don't really have much to add in the sense that I personally prefer subpericondial, but I fully get Ashim's and Sunil's point about being suprapericondial. My only preference is purely because of vascularity. I think it's quite nice to have a subpericondial plane. I think it's easier, as I said, in Indian skin, which is thicker skin, so it doesn't really matter if you're subpericondial or suprapericondial. In terms of the lateral exposure, I think it really depends on what you're trying to achieve. So if you are just mainly dealing, for example, with a tip issue and you're not going to be going to the dorsum, you may not need to dissect so far laterally in the dorsal region. Although for most cases, I will tend to dissect about halfway across the lateral wall. So if you go to the lateral wall, you're going to be exposing about halfway down the lateral wall, because that will tend to give you enough exposure. What you're trying to do is limit the amount of soft tissue dissection you get to reduce the amount of edema, but at the same time, you obviously need enough exposure. So you have to find that compromise. And I think if you go about halfway down the lateral wall, that's normally fine. Now, some people, and certainly those people who are advocates of using powered instrumentation, for example, at the moment, flavor of the month is piezo, or a flavor of the year is piezo, should we say? It's a ultrasonic instrument. But whether you use that or drills or whatever, and certainly if you're going to be doing lateral osteotomy using these instruments, then you have to do what's called an extended lateral exposure, sort of an extended open approach, if you will, where you really have to dissect all the way down along that lateral wall, right down to the nasofacial groove, where you're going to be making your lateral osteotomies using the piezo. So I think it does depend to some extent on what you are trying to do and which method you're going to do it. But I think about halfway is fine. And then finally, let me just tackle Pechengui's. Now, Pechengui's, again, has become almost very topical of late, and there's a lot being talked about Pechengui's ligament. When I first started, it was just a thickening of tissue that most people ignored, but I certainly do feel that if you can preserve the Pechengui's, or at least reconstruct the Pechengui's, it can help with supratip approximation, which is very useful when you're trying to obliterate the supratip space. So what I tend to do is I dissect around, find the Pechengui's ligament, and then effectively cut it flush. You can either cut it flush with the skin, although I tend to cut it flush with the cartilages. But then I make a note. I either mark it or make a note of what it is. And at the end, you can just put a stitch to reapproximate it back again. I think where it helps is in that supratip, recreating a supratip break or reapproximating that supratip region. So I think, again, it's become very fashionable, Pechengui's ligament, in the last few years. And, whether it makes a huge amount of difference, I don't know. But I tend to now at least mark it and try and reapproximate it at the end. So Neil, tell us what you're doing now.
After the exposure of the tip and the mid vault and the upper vault, Then we expose the septum. So for the septum exposure, it's depend on person to person. Sometimes if you need only the septal cartilage harvesting and there is no need to the septoplasty or the functionally patient have doesn't complain, then in case you can harvest your septal cartilage through the Killian's incision through the transnasally. So there is other incision, that is the hemitransfixation incision we also use for the septal correction. But if your patient have a caudal septal problem and the caudal septal deviation, in that case your incision on the prominent, like in this patient, then in that case your incision should be on the margin, on the margin of the caudal septum. That is the hemitransfixation incision from top to the bottom, from the anterior septal angle to the posterior septal angle. But so if the patient the caudal septum is the central, but if the patient have the posterior and the middle septum problem, then your incision is the Killian's incision. So the Killian incision, that is the junction between the vestibular mucosa and the nasal mucosa from the top to bottom. So, but if you go for the open approach, then you can separate this both medial crus and first hold कर लेना इसको. वीरू कहाँ गया? मैं बुला रहा हूँ. वीरू को बुलाओ. So पकड़ लूँगा. So basically, you separate the both side of the medial crus, and then the first structure you identify, that is the anterior septal angle. So the anterior septal angle is the angle between the this dorsal part of the septum and the caudal part of the septum. So this is the anterior septal angle area. So always, and this is my advice to my junior colleague, that once you start the dissection for the septum, for the mucopericardial degloving, it's a little bit difficult step. So you keep patients, especially in this area when you separate this one. उसको नहीं boss इसको. मैं पकड़ लूँगा चल. इसको ठीक करना है यार. So you can use the Cottle's elevators, but I always use the Dr. Pond technique. By the seizure, you do the fantastic dissections, and you keep, if you keep the patients, then you separate first from the cephalic part of the septum, because the mucopericardium in that area is less adherent, and then go posteriorly in the first you degloving the mucopericardium on entire septal cartilage, and then go posteriorly on the perpendicular plate, and then later in the posterior inferior in the vomer part, and in the last in the maxillary crest area. So in the junction of the perichondrium and the periosteal flap, there is chance of the perforation. So care should be taken when you switch or your dissection from mucopericardium to the mucoperiosteal flap on the crest of the maxilla. So then you assess what your patient have. If your patient have the functional problem, then you correct by the septoplasty, and you just leave the caudal and the dorsal strut at least 1.5 centimeter caudal part of the septum and 1.5 centimeter for the caudal support for the dorsum and the caudal part support, and last we harvest or correct. 1.5 centimeter. Yeah, 1.5 centimeter. So now for the better exposure, 15 number blade, we separate the upper lateral cartilage and the septum. But the important thing before you separate the upper lateral and the septum, then you complete elevate the mucopericardial flap. You complete elevate the mucopericardial flap. So we separate the upper lateral cartilage and the septum. So if you have a crooked nose, then this separation is very important, because in a crooked nose, there is a two type of the force that have the causative agent of the deviation. That one is the extrinsic force and the another is the intrinsic force. So the extrinsic force on the septum through the attachment of the upper lateral and the vomer and the perpendicular plate. So when you release the attachment between the upper lateral and the septum, then you eliminate the force on the septum. So just to allow the septum come in the midline and reorient. And another advantage, when we separate this upper lateral and the septum, then you assess actual degree of the deviation and actual degree of the hump. Focus it, please. This one is good. So this separations of the upper lateral cartilage and the septum is the important thing. And then we harvest the septal cartilage after the med. हाँ ठीक है, it's okay. एक focus करना वीरू please. So I complete degloving my mucopericardial flap, and now I harvest the septal cartilage. For the better, you can mark 1.5 centimeter dorsum and 1.5 centimeter on the caudal part. अभी तो फिक्स हो रखा था सही. So I make a incision. Now you can use nasal detector. Give me a detector.
Sunil, you say 1.5 centimeters. I mean, I think the books, and if you read most books, etc., most people will read that it's 1 centimeter by 1 centimeter. But I would agree that you want to leave as much as possible. And I think the key thing here is to remember, particularly for people who are starting out, they might leave 1 centimeter by 1 centimeter or a little bit more even, and then forget the fact that they're going to need to remove some of the dorsal cartilage, for example, if the patient has got a hump. So if you've left 1 centimeter, then you take 3 millimeters off, then you're only leaving 7 millimeters behind. So factor that in. And I think, as Sunil says, you want to leave really as much of the cartilage as you can. Only take out what you need. Equally, if you need more, then I think you can leave 1 centimeter by 1 centimeter. That is enough. So I think Sunil's being a little bit conservative with 1.5 by 1.5, but I think the principle is correct in the sense that you want to leave as much as you can and only take out as much as you need to.
So we can preserve the 1 point. You are right, sir. But I preserve in this 1.5 centimeter for the dorsal and the caudal support, and we assess the caudal septum later. In this patient, the caudal septum is deviated from the left side from the midline. So first, we just fix this caudal part of the septum. We relocate this caudal septum from the antenasal spine. So
what do you do when there's severe caudal deflection?
Yeah, this patient have the caudal dislocation. So
no deflection. I mean, when the caudal cartilage is extremely deformed and bent, how do you handle it?
Yeah, now it's good. Now it's good.
Asim, I've seen you in our patients. I've seen you always doing something with a columella, some strut grab or some support or something like in almost every patient.
Septal extension graft.
This columella support.
Yeah, a septal extension graft will sort of move beyond the membranous septum and create a columella support along with it.
So this space, the caudal septum is towards this, and this is the antenasal spine. Can you appreciate one? This is the antenasal spine.
Beautiful.
This is the antenasal spine. So if we not fix in the midline, then it's very difficult to straight the tip. So there is different method to fix this caudal part of the septum with this antenasal spine. There's so many methods, but some people use by a burr hole this antenasal spine and fix but a very good 40 PDS or 50 PDS. It's a very good method by Dr. Pon that you just take a 40 or a 50 PDS suture and then just through the periosteum of this antenasal spine.
Beautiful, beautiful. Yes.
Yeah, so Sunil, when I come to visit you in Jaipur, we tend to use a 40 PDS. Actually, in the UK, it's only because we don't have a 30 PDS available. I would use quite a thick suture here. You want to really anchor this, so I would tend to use a 30 if you have it, but and a 40 as the minimum. I think 50 is just too thin. So really, you want to get this anchored, and important thing is show them this maneuver where you can lift the skin, this lifted head after this suture. So lift the head with this suture now. Before you put that in, Sunil, before you put this throw in, okay, he's not hearing. So I think the really important thing about this suture is to make sure that if you are going to put it through the periosteum, that is definitely through the periosteum and not just through soft tissue, because otherwise it will cut out. So one way of checking that is when you put the bite through the periosteum, you literally lift the head up with that suture. So if you can lift the head with the suture, you know you're in the right plane and you're in the subperiosteal plane, as opposed to if you're going through soft tissue, it will just cut out.
Yeah. So I just periosteum of the antenasal spine, I suture in the midline. So it's very simple and easy method to fix.
In case you need a columnar strut graft, you will suture the same place?
Yeah, we first fix the caudal part of the septum in the midline, and then because if there is caudal part of the septum is weak, then we need for more distal support, then we use a small part of the septal cartilage and we overlap the caudal part for the septal extension graft. So but if your patient have a most deviated or deformed caudal part of the septum, then we use the caudal septal replacement graft for the distal support.
You'll show sometime later?
Yeah, later. Cut it.
You know what I used to do in the past, and I've learned this from you, Sandeep, is that I used to do a separate columella support, and occasionally you had the problem with the click. When the patient says that when he moves the columella septum, you get a click. And then I learned from you to create a septal extension graft, and that seems to work out much better.
I think in your patients, the thick skin patient, the thick, heavy skin patient, the main advantage of the septal extension graft really is that it provides a strong foundation onto which you can then hang your tip. The problem with columella struts is that they're fine for thin skin patients, and that's enough support for the columella. But when you've got a heavy, thick skin patient, over a period of time, the columella strut is just not strong enough to withstand the contraction forces of heaviness of the skin envelope. So this is why I favor the septal extension graft. I think it gives you a really strong foundation. Then you can hang your tip onto it. So effectively, you're doing a tonguing groove onto the septal extension graft. So it's like a modified tonguing groove. And there's many advantages of that. The most important being is that extra amount of support you get. But also, if you're doing it onto a septal extension graft rather than just a tonguing groove, you will tend to find that you don't get so much rotation, which is the other problem with tonguing groove. You just get too much rotation. So, I mean, I think there's many reasons for using a septal extension graft. I mean, I actually give a talk on septal extension grafts where I quote 10 good reasons to use a septal extension graft. But probably the most critically important one is the fact that the foundation, and particularly in the Indian skin type, where actually the cartilages, even sometimes with the septum, is quite weak. So you're effectively a septal extension graft, you are adding strength to that cartilage. And I think that's one of the main reasons why it's worth doing that.
Yeah, but one point I wanted to make for those of us who want to do this procedure is that the superior connection to the keystone area and inferiorly to the anterior nasal spine of the existing septum should be absolutely perfect. Otherwise, a septal extension graft won't really work well. Am I correct?
That's correct.
Yeah. Now, the problem here is that when you have a very grossly deviated anterior nasal spine and you fracture it, it kind of becomes floppy. So what do you do for that?
Yeah, so I mean, really what you ideally want is that...
then the base is destabilized. You know?
Yeah, so when the base is destabilized, well, you can, I mean, and I've seen it described, people putting plates in to effectively hold that anterior nasal spine back into the midline. So you can almost put a little mini plate and hold that spine. So you're attaching that spine back into the correct position. What I tend to do is if you really don't have spine, I will tend to use an extended septal extension graft, which will extend down. And then I find a piece of bone in the midline and then effectively add or attach that septal extension graft right down low onto whatever bone I can find. But one of the problems with that is they sometimes do feel that clicky sensation, which you've already mentioned. So I think it's a difficult problem when you've got an anterior nasal spine, which is so far off, because if you fracture it, I think one of the risks is, as you say, you destabilize the base. And if you're one of the most important thing about septal extension is that if your septum isn't straight and you put a septal extension graft on it, then you may end up with a deviation, which will then pull the tip across. So you have to factor all of these things in. But I've certainly seen, and I've done it once myself, where you use a little mini plate, a little sort of four-hole mini plate to effectively reattach the anterior nasal spine back into the midline using using screws. As
You've never had a problem with extrusion?
No, if you're using titanium mini plates, it's like any other titanium mini plate anywhere else in the body. They hold extremely well. The only problem with it is, by the time you've actually used the mini plate and screws, and certainly if you've got a private patient, these are expensive. These are expensive things. I mean, some of these mini plates, particularly the very fine titanium mini plates, can cost, well, in the UK at least, hundreds and hundreds of pounds, with the screws. So it adds enormous cost to the surgery potentially. So the only patients where I've ever done that has been in our NHS, where we've got these plates things available rather than having to bill the patients for these separately. So because it is an expensive thing. So I think, but there's certainly a way of doing it.
NHS pays for cosmetic rhinoplasties? That's amazing.
Well, no, it's for functional or reconstructive things. So the NHS doesn't allow us to do cosmetics. At the moment, I'm not doing anything in the NHS, or very little. We still haven't been allowed to operate mainly.
So after harvesting my septal cartilage...
Sorry, I just had one question. I don't do anything. Can the bony spur be drilled rather than fracturing and putting it back? Why not just use a drill to take away, shave off whatever is the...
Yeah, you can do that. Actually, you can drill that, and often we do that. Just like you say, the spur.
Yeah.
The problem, I think the case Ashim is describing, and they're few and far between, admittedly, so you don't face this problem very often.
Yeah.
More often than not, you see a spur of the, and then you can just drill it, like you said. But I think the problem is when you've got it's often when they've had a fracture early on in life and things have moved, that the whole anterior nasal spine is sitting almost, laterally all the way halfway across. In which case, there's nothing you can do. You can drill it, but you still need something to reattach the caudal septal onto. In which case, as I said, you can either just put a suture through whatever bone you have in the midline, anchor it, and make sure you've anchored it, or reattach whatever bony spine you've got there. But then, as I say, you can't do that. Sorry, Sunil, I know we're using your time here, but it's an important point. If you're going to reattach the caudal septum back into the midline and you haven't got an anterior nasal spine, if you just try and attach whatever the caudal septum is there, it will tend to pull the caudal septum down and almost cause a dip. You'll end up with a saddle deformity. So what you need is a extended septal extension graft, i.e. the length has to be long enough to attach down low, and you have to put an extended septal extension graft. Don't just try and put the caudal septum in. Sorry, Sunil, carry on. Sorry, we're talking over you. I apologize.
Sorry, Sunil.
Yeah, he is going to show. At least, just in brief to answer your question,
yeah,
agreed with you Rhinoplasty is all about what I believe is, dismantling
Yes, and
the nasal
reassembling.
skeleton, the nasal bones, the upper lateral, lower lateral cartilage and septum, and reassembling everything again.
I think conceptually, I think rhinoplasty
As
is
simple
far
as
more
that.
difficult than microtia repair,
Just
simply because it is a midline procedure. So the right and the left, the healing forces are on either side of the body. And I think that is where, because you're dealing with two sides in the midline, whereas in microtia, I'm dealing only with one side. So anything that is pulling, and therefore I don't know, these osteotomies and the fracture, the trauma that goes to the tissue, I think the tissue responds correspondingly.
it heals well, man. It heals well. So,
Of course it is. That's how these guys are giving great results.
Ashish, when you
let
talk
us
about
see Sunil
microtia being less difficult, I think you're being very modest here.
No, I'm being realistic. The reason I don't do rhinoplasty is I don't understand it.
So let us see Sunil first.
Carry on. Yeah.
How he does osteotomy, and then we'll discuss.
So after the harvesting of the septal cartilage, I put the cutting sutures to just decrease the dead space and to prevent the hematoma formations. So there is if there is a no infiltrate work, then there's no need to the packing to the patient, because the post-operatively the packing, when you pack the nose, then the patient has some discomfort. So by the cutting sutures from the anterior to the posterior side, from the top to bottom, then you can prevent and obviate the need of the packing. So now the exposure of the inner framework and the septum. First, we discussed then how can we modify the bony vault. So for understanding of the bony vault modifications, first we have only one procedure by we can change our modification of this bony vault, that is the osteotomy. So first, understand what is osteotomy. So osteotomy is a controlled fracture of the nasal bone and adjacent ascending process of the maxilla. So really, it's a very essential procedure of the rhinoplasty. But there is a lot of challenge in osteotomy. What challenge in the osteotomy? Because this is the procedure, while we performing, we cannot see this procedure. So that is a big challenge. And another, because the person have a lot of anatomy, great variation in the nasal bone length and the size of the nasal bone. So you should have the knowledge about the proper osteotomy, that your patient is need or not osteotomy first. And the second, you have to know the morphology of this nasal bone. And you have the knowledge of the different type of the osteotomes, and which type of the osteotomy you need, what sequence of the osteotomy, what type of the osteotomy you need. So you decide before to do the osteotomy. So the important thing regarding the osteotomy, the anatomy of this nasal bone.
So Sunil, tell us clearly, like beginners we are.
Yeah.
What is lateral osteotomy? What is median? How to go about? What is low to high? We don't know anything about it.
So really, it's very simple. If you deal with the lateral most part of the nasal bone, then that is the lateral osteotomy. And if you deal the medial part of the nasal bone, if you separate the nasal bone from the septum, that is the medial osteotomy. And if you deal the part between the medial and the lateral, that is the intermediate osteotomy. And from the transverse osteotomy, when you separate the nasal bone from the top. So these are the different
types. How do you know the junction of the nasal bone and the maxilla under the skin?
Yeah. So for the lateral osteotomy, we have the two methods. If you do from the inside, that is the internal osteotomy. And if you do from the outer side, that is the external osteotomy. Yeah. So if you do from the outside, that is the external osteotomy. And if you do from the inside, that is the internal.
So one side internal, one side external.
Yeah.
Can you please?
Yeah. So for the first, we show the nasal speculum.
I have seen so many times Ashim and
There is two types of the osteotome. One is straight osteotome, another is the curved osteotome. And one is guarded osteotome, another is the unguarded osteotome. So if we use a guarded osteotome, then for the beginners, it's easy because the guarding at the guarding end of the osteotomes throughout the passage of the osteotome, you can feel. So where you are working, that is the easy. But again, it's a matter of the choice, how your bosses are doing, how is your training, or how you are more comfortable.
You are the boss today. You tell us.
So give me. So for the lateral osteotomy, the two thing is the important for the marking. Two things is the important. One is the pattern of the osteotome, and another is the approach. So the pattern of the osteotome, once the osteotome is discovered by the Joseph, then at that time the osteotomy from the lowermost part of the piriform aperture to the upper part of the nasofrontal junction is the same pathway. That is the low osteotomy.
So you go ahead.
Yeah, but consequently, when we use that, then the pro and cons of that method is we realize. So Webster realized, then rather than go from the lowest most part of the piriform aperture, because when we go through the lowermost part of the piriform aperture, then we damage the Webster triangle. So we go little up higher. High. There is two words. One is high, another is the low. High, that means towards the dorsum, and the low towards the maxilla. So by if you go little high, then you can preserve the Webster triangle area, and consequently the post-operative the breathing problem you can prevent. Another, if you go rather than low, high in intercanthal line in the top, then you can prevent entry in the dense thick part of the nasal bone. If you enter in the dense thick part of the nasal bone, then there is the bone is feel, that is you create a rocker deformity. So we make a incision first. There is a stab incision, 15 number blade.
Where exactly?
From the anterior end of the inferior turbinate, we make a 3 millimeter around the horizontal incision. This is my inferior turbinate. So just above the inferior turbinate, this is the incision. This one. Okay.
Yes, go ahead. Meantime, you do.
Yeah.
I have a question for Ashim.
Yeah.
Ashim.
Yes, boss.
No.
I know you have done so many at our place. I still want to know. This incision on the inferior turbinate, you always, I don't know, I still not understood. What is external nasal wall, what is internal nasal wall, how you protect, how to improve, how you diagnose? Can you tell?
इसके बाद में कर लेंगे.
A little bit
after this one. So the first, when you engage your osteotome, then this guarding end is on the outside. This guarding end is on the outside. So you engage your osteotome in your incision, and first you little bit vertical, not like this. You have to like this.
After the mucosal incision?
Yeah, after the incision, then you engage this osteotome
directly on the bone.
Yeah, directly on the bone, and then you feel this guarding end. You feel the guard. So my thumb, you feel this guarding end. Okay, and then the osteotome, the direction is osteotome is not like this, because we do the high, low, high pattern. So this osteotome is in the vertical, and you use that 2-tap technique. Tap, 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 like this. Tap, 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 tap. And gradually you go down. Tap, 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 tap.
Dr. Santadeep.
Tap, tap.
Can you hear me?
Tap, tap. So
yeah, I hear you.
So once you are in the nasofacial groove,
how do you know?
Then you, I feel my guarding end. Okay. I feel my guarding end. So tap, tap. Tap, tap.
I've seen people doing tap, external tap, as tap, well, tap. Very comfortably. So seen them doing hundreds of cases, like Dr. Virendra, I told you. with equally good results. How do you choose between external and internal osteotomy?
So, Satish, let me explain. Let me explain my thought process on this. I don't think it makes a difference, and in many ways, the external percutaneous osteotomies are an easier thing to learn because it's very visual. You can actually just feel exactly where you are. Whereas what Sunil is doing now, which is the high, low, high, you see he's having to feel it all the way. So just to finish off with what Sunil is doing, he's gone high to low. He's now in that deep nasofacial groove, and now he'll start going high again. There's two ways of knowing where you are. Number one is, as you can see, his thumb is constantly feeling where the guard of that osteotome is. And secondly, you can hear the difference. As we spoke about earlier, the lateral wall of the nose consists of the frontal process maxilla, which is very hard, and you can hear a much harder sound. And as he comes up now, Sunil, just carry on with your tap tap. It'll start feeling much softer. You'll hear the difference in the bone. So it's a tactile thing. You can feel it, but it's also a audible difference. You can actually hear the difference when you're in the thick maxillary bone.
Anytime you do external?
Yes, so going back to the external, one of the advantages of the external is you don't have to do what Sunil is doing. You can just kind of see. For me, I tend to use the external only if I have a little spicular bone that I just want to read. So after you've done this, if you end up with a tiny little spicule that hasn't quite reduced, you can just do a little percutaneous incision just to get rid of that little spicule. For me, the main reason why I switched, so I learned how to do it both ways, but the main reason why I tend to do this is you tend to get much less bleeding. And we did a study on this. We did a study doing one side percutaneously, one side endonasally, as Sunil shows, and we found that with completely yeah. So what we found was with independent observers looking at this, that there was much less bruising seen on the side where you went endonasally. So this is the main reason why I prefer an endonasal rather than external. I think the criticism of the external is the scars. You can potentially cause scars. Well, you know what? They heal extremely well. And it's very, very difficult to see them. I have to say, people say they're invisible. I don't think they're invisible. I mean, they're only 2 millimeters, so it's very difficult to see. And there's certainly one medical legal case that I was asked to be a referee for, where the surgeon had not told the patient he was going to be doing these little scars, and the patient got very upset that she could see these 2 millimeter incisions and had not been warned about it. But actually, it was very difficult to see. And so generally speaking, I don't think it was the scars that was the main problem there. She was more worried about other things, but it was the one.
So yeah. Once you reach at the level of the medial canthus, then you change your directions in the oblique manner. Tap, tap.
At what level?
At the level of the medial canthus.
At the level of
never go beyond this. Never go beyond this.
Then how you get to know that there's a time to stop?
If you go in the midline, and then you feel your guarding and then you stop.
Okay.
So now,
yeah, sound or anything.
Yeah. So now, once you finish this, then you rotate in the clockwise direction like this. So now my nasal bone on this side is free.
Sunil, can I ask you one thing?
Yeah.
For audience sake.
Yeah.
I know you are expert.
Yeah.
You can do from inside.
Yeah.
We can see what you're doing.
Yeah.
We can't see exactly where your bone is cutting through.
Yeah.
Can you show on the other side?
Yeah. Yeah.
From outside,
Caesar then.
After splitting the skin, where exactly you're breaking the bone?
Yeah.
Can you please?
Hold it.
Okay. One question I had, Sunil.
It's a very important step.
Sunil, one question is for the sake of the audience. When would you do, like you have done a high, low, high osteotomy on this side, right?
Yeah.
When would you do a low, 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 and then do an intermediate osteotomy?
Yeah.
Is there an indication for that?
Yeah, it's depend on the deformity. Suppose if your patient have a crooked nose, and in the crooked nose, the shape, one is the concave side and another is the convex side. So either you do the medial or lateral, it doesn't matter. But in a crooked nose, the sequence of the osteotomy is most important. In that case, if you do the double osteotomy and the intermediate osteotomy, then first you do the intermediate osteotomy, because if you do the lateral osteotomy first, then how can you do a destabilize bony part? So first you do the intermediate osteotomy. And another important thing, if you have the concave side and the convex side, so like Dr. Pon always said that the concave side you treat first. So if you free the concave side first, then when you do the osteotomy on the convex side, that it allow to come in the midline. So the sequence of the osteotomy is important, and either you use the external osteotomy and the internal osteotomy. Suppose your bony deformity is deviated but bony vault is symmetrical. In that case, you use internal osteotomy, that's enough. But sometimes if your bony pyramid is asymmetrical, your one side length of the bone is longer than other or more convex, in that case, in one patient, you cannot complete by only one procedure. So in that case, you need sometimes external osteotomy or the internal osteotomy.
Yes. Thank you. Sandeep, can I ask you one thing? I know you have done thousands of rhinoplasties. You have seen from worst to best. For junior colleagues, people who want to learn like me, I've seen people doing external osteotomies very good. You know, they'll make a small step incision and do osteotomy, and it goes very good. I've seen like Sunil has done the internal osteotomy. I've seen you doing internal, external, everything. What is your message? You know, we want to know the pros and cons. What is your message? You're the master.
As I said, I think the message is you do what you feel comfortable doing.
Any particular situation where you want to go external or you want to go internal, please.
Yeah. So as I say, my own, I think it's a preference thing. My own preference is to do endonasal. I think there's much less bruising, and you don't risk any scarring on the outside. However, as I said, the scars are minimal. And so if you are going to do it, if you're going to use the external osteotomes, make sure you use a very fine osteotome. It mustn't be 5 millimeters. It mustn't be 3 millimeters. You need a very sharp 2 millimeter osteotome, really the minimum amount of trauma externally and the minimum amount of incision externally. And just be prepared for the fact that they may bruise a little bit more. But other than that,
it heals up very well.
Yeah, it does heal. I mean, I'm not saying it doesn't. As I said to you, it's very, very difficult to see. I won't say it's completely invisible. I think if you look hard enough, you might be able to see it. But for most patients, it's not a problem. It's, you know, I did a case last week on a very high profile girl in London. I mean, she's extremely high profile. She's actually she's on Instagram. I think she's got 500,000 viewers. I mean, so this was a real pressure case, as it were. And she ended up with a little step deformity, which I had to do a little percutaneous incision. I mean, and it's fine. And so there's no reason why you can't do percutaneous. It's just that you do tend to bruise a bit more. And she definitely bruised more on that side than she did on the other side. So this is the main reason I like not doing that versus doing it. So, and you said Virender does them percutaneous. You may well have seen them. I think Virender was influenced by Wolfgang Gubisch. And so the thing is, the Gubisch has always done them externally. And honestly speaking, a lot of the European surgeons, and including my ex-boss, Tony Bull, who's now passed away, always used to do them percutaneously. And that was the de facto standard. You would do a percutaneous suture. Percutaneous osteotomy. But I think with the endonasal, I mean, I think it certainly you have to learn it, and it's a little bit more tricky to learn. But, you know, for me, I think it works extremely well without the need for an external incision. I mean, Sunil, show where you're making your lateral osteotomy. I think what he's showing there is a lateral osteotomy and an intermediate osteotomy for certain conditions. So Sunil, show the landmarks for this.
In fact, for me, the only place where I use the percutaneous osteotomy is when I decide to do a transverse osteotomy. You know, that's where I really feel the need for the percutaneous osteotomy, really, when I'm doing a lateral and medial osteotomy that's all internasal.
Yeah, no, I agree. Or an intermediate osteotomy, same thing. So yeah, I'd agree. I mean, I've moved very much away from doing percutaneous osteotomies, but to answer your question, Satish, there's no reason why you can't do percutaneous osteotomy. For me, it's mainly because I think you get far less bruising. And there's certainly a little bit more to be learned by doing it endonasally, but it's like everything else. I mean, you know, you can take the easy way, which is a percutaneous way, or you can learn how to do it the endonasally and hopefully have happier patients because they bruise less.
So look,
Sunil, what are you doing? Can you tell us what you're doing, Sunil?
Yeah, I am coming to that. Sandeep, we want to have you more and more to elaborate on this aspect, because this subject is something, you know, there are a lot of controversies, a lot of people doing different things with actually good results. I know people in India who are doing good rhinoplasties. Ashim is champion, Virendra Gaisaj is champion, Satish Patil you may be knowing,
Yeah, I know
Shivanand,
Satish,
you
yeah.
may be knowing, Dr. Vikas Kulkarni you may be knowing, our friend Dr. Sudeep Munjal you may be knowing. They are doing excellent work, believe me. But still, there are a lot of questions unanswered, a lot of burning questions, a lot of different techniques. We want to have you more and more. Promise me in lot many webinars coming up. The issue is, being a novice surgeon, how can we improve our technique? Because we always under pressure what is right or wrong.
Yeah, and there isn't an answer to that.
Yes,
It's like,
Sandeep, you have been global teacher. You are trained Sunil, who is doing wonderful work. I'm still learning from him. You, Ashim, I'm always learning from him. See, you have to come up with something, like something you have to follow. We really want to learn from you. And we
no. The problem,
come to India more and more.
Satish, the problem is if we teach you rhinoplasty, there's nothing left for any of the rest of us. I mean, you do everything else, so at least leave one operation for the rest of us to do.
So look at this is my nasal bone.
Yeah.
This is my nasal bone. So this is nasal bone, and this is the ascending process of the maxilla.
Yeah.
So there is one important thing. There is a two type of the width. One is the dorsal bony width, and one is a bony base width. So there is a two different things. So suppose if your patient have this over wide portion, yani that patient have the dorsal bony width more, then in that case, then high osteotomy is good.
Okay.
But suppose if your patient have over wide bony base width, in that case, if you do the high, in that case, you have a stair-step deformity. So this is the important message for the which type, because in the rhinoplasty.
So when you make the osteotomy?
Very good point. Very good point, Sunil. That's very nicely elicited. Very nice.
Thank you. So
how do you prevent the stair-step deformity?
Yeah, for stair-step deformity, if you do the internal osteotomy, then this is my piriform aperture, if you can appreciate it. So this is my attachment of the upper lateral most part of the upper lateral. So I want to preserve this area, so I go little bit higher up, like this. And then, let's go, tap.
Sandeep,
tap.
Can I ask one question? In brief, without wasting time. I have seen from Seoul
Yeah.
You must
Yeah.
be knowing the one of the most versatile surgeon from there,
Jung.
Jung.
So
And he has done couple of workshops with us. He's one of the fellow, Dr. Gaurav Medikari. I don't know, you know him, don't know him, but absolutely following him. He does very good rhinoplasties. His concept, Dr. Jung has been doing more than 20 rhinoplasty for more than 25 years. Every day more than 20
ये
rhinoplasty.
प्रिजर्व कर लिए.
What he believes in every case, almost every case, what I have known from Gaurav nowadays is an open rhinoplasty, open osteotomy with a very, very small incision. At this point of time, why I'm asking, Sunil has mentioned that you have to prevent a stair-step deformity. Can you elaborate this? How we can prevent?
So the stair-step deformity is so the important thing, as Sunil is showing here, is low down on that nasofacial groove. So where you don't want to be is where that just where the nasal bone is. Your incision, in many ways, irrespective of whether you're dealing with the base or indeed the dorsal width, you want to make sure this is low down, because if you make your incision, if you make your osteotomy higher up on this bone, you're going to end up with those stair steps. So the key bit is what Sunil is showing here, which is he's deep. He's right down on that nasofacial groove, right down there. And then as he comes up, so this is the low bit. He's gone from high.
You feel the nasofacial groove under the skin.
You feel it. You feel it. You feel it. You can't see it. You feel it.
Okay.
You feel it.
You do from inside and then show from outside.
This is my guarding end of the osteotome. But if this is my nasofacial groove, so I feel my non-dominant hand finger like this one. I feel this one. So once you are.
So what you're feeling the edge of that osteotome, which you can see.
It's a matter of feeling. I feel this.
Ashim,
Yeah.
Can you correct this stair-step deformity if it happens to occur?
Yes. In fact, I often talk about it in my lectures, in that generally this happens in spite of going very low down when you have a grossly deformed nose. So in that case, what I do is what I call a far lateral osteotomy. So even if you go right down to the nasofacial groove, when there's adequate deformity, you will still feel a step. So you go still further laterally and then take a small wedge of bone, and you don't take it away, but you just refracture it. Again, do a far lateral osteotomy exactly 2 millimeters or 3 millimeters away from where Sunil is working. And that will prevent that stair-step deformity.
So my nasal bone is free. Now my nasal bone is completely free.
That's a lovely visibility.
Okay. Yeah. So this is a high-low high osteotomy. So now after the lateral osteotomy,
you didn't do paramedian or median so far?
Because we free the completely on both sides. But if you go for we go for the paramedian. If you go for the intermediate osteotomy, that we do the osteotomy from this part, from the mid part, from this part, the nasal bone. So वो देना इसको separate करना. So we go for the medial osteotomy. Medial osteotomy de. Actually, the medial osteotomy is a paramedian osteotomy. We engage this osteotome. Just 1 or 2 millimeter lateral to the septum. So again, we feel this end under the skin like this. And this medial osteotomy is a 20-degree offline position like this.
So this is paramedian actually?
Yeah, it's actually paramedian position. It's the paramedian position. Tap.
No, I want to know. This is paramedian.
Yeah.
I'm not talking of median.
Yeah.
What is medial osteotomy?
When you medial osteotomy, then if we put this osteotome in the mid part and then we separate this both bone like this one. This is the medial.
Okay. Now.
So we go for the paramedian osteotomy.
Ashim, can I ask you one thing?
Please, buddy.
You mesmerize with your septal presentation, but I have so many questions unanswered so far. Please
So now my nasal bone is
When
completely
you
free.
go for a complete, removal of the septum and putting it back, what do you call it?
Extracorporeal.
Extracorporeal septoplasty.
And when you go for a routine septoplasty, please, if you don't know when to go for extracorporeal, when not to, can you give us a clarity? They're very confused about it.
Okay, the only reason I would go for I don't routinely do an extracorporeal septoplasty. The only reason I would do an extracorporeal septoplasty is when there is a gross high deviation along with the gross anterior deviation of the nose. In that kind of scenario, I would be anterior deflection with a gross high deviation. That is where I would do an extracorporeal. Otherwise, 9 times out of 10, I will not do an extracorporeal septoplasty. I'd probably do a MOST technique, that's the anterior extracorporeal septoplasty, leading a caudal end of the septum, or a standard septoplasty or a anterior septal reconstruction. But extracorporeal, when there's a double problem, one is a extremely high deviation, and the second one is with the anterior gross deflection. That's the only situation where I do an extracorporeal. Sandeep, any opinion on that?
No, I'd agree entirely. I think, again, a lot of Indian surgeons have been influenced with Wolfgang Gubisch, who's traveled a lot to India.
Yeah.
And it's not to say that Wolfgang is wrong, but he is, shall we say, a little overzealous with doing extracorporeal. I think one of the other advantages as ENT surgeons we have is we're very comfortable doing septal surgery, whereas often with plastic surgeons, they're a little bit less comfortable and they find it easier. But I think I do an extracorporeal septoplasty maybe once a year. All right. I think I have lots of different techniques that I can avoid an extracorporeal septoplasty for, and hence it's a very destructive operation that can end up giving you a lot of problems if you're not careful.
Yeah.
Wolfgang, who teaches and has taught in India a lot, is a real master at doing it and get some beautiful results. But I think there are different ways of achieving the same thing. So again, I think where extracorporeal septoplasty has kind of taken this huge popularity, certainly even in India, is amongst a lot of people who have either worked with Wolfgang or have been taught by Wolfgang. And of course, he has written more about this than anyone else anywhere in the world. But, the reality is, other than Wolfgang, there's very few people who do as many extracorporeal, because I just don't think that there is a necessity to do that. There's lots of different ways of being able to achieve the same thing without having to do it.
Yeah, I'd agree with that. 9 times out of 10, you don't need to do that.
Yeah.
Tell me what you're doing, Sunil.
So this is my anatomy of the keystone area.
Exactly.
If you can appreciate, this is the central part of the keystone area. This is my nasal bone, and this is the cartilage, and underneath the bony septum, and this is the upper lateral cartilage.
Yeah.
So you appreciate this nasal bone overlap this upper lateral cartilage.
Yeah.
So the maximum overlap in the central keystone area rather than in the peripheral. In the peripheral, around the 5 to 6 millimeter, but around the 14 millimeter in the center. So sometimes when the nasal bone is short, then obviously in that patient, then this upper lateral cartilage is long. So if you do the osteotomy in that case, that great care should be taken, because if you do the osteotomy in that case, that the nasal bone have the more chance of the fragmentation. So we lost this support. So this upper lateral cartilage is collapsed inferomedially. That is called the inverted V deformity, because in that patient cosmetically this margin of the caudal margin of the nasal bone is prominent. So we preserve this. If your patient is already short nasal bone, then that is a contraindication of the osteotomy, and you do very cautiously. So that's why the pre-operative analysis is the foundation of the rhinoplasty. So earlier you assess what is the length of your nasal bone, because the nasal bone have the great length and variation in the length. So you pre-operatively you assess what is the length of your nasal bone, what is the length your upper lateral cartilage, and what deformity you have, and what type of the osteotomy you need or not, because with indications certain things have the contraindications. So when nasal bone is very short, then that is a contraindication of the osteotomy. And some people, if you have the more chance of the scar formation and use eye heavy glasses, that is also a contraindication of the osteotomy. So basically this is the peripheral keystone area, then the central area. So we finish, I think, this bony wall deformity, and then the mid wall modifications. For the mid wall modification, there is very important structure, the internal nasal valve area. This is the internal nasal valve area, and this angle between the attachment of this upper lateral and septum, that is the 15 degree, 10 to 15 degree. So we always maintain this internal nasal wall area patency V attachment.
Ashim,
Yes, boss.
what is external nasal wall, what is internal nasal wall? Can you make us an understanding of what all these?
The external nasal valve is the region caudal to the internal nasal valve. Okay, so if you medially and superiorly you have the internal nasal valve, the external nasal valve is caudal to it. So what is the external nasal valve? It's superolaterally by the caudal end of the upper lateral cartilage, laterally by the nasal ala and the bony piriform aperture of the maxilla, and medially by the septum and the columella.
Sandeep,
Yeah.
you several times, you have shown us, demonstrated us in Jaipur, lot many times, spreader graph for the internal nasal wall.
So
Can you, in literature we read a lot of things about suspension, about other things for the internal nasal wall. How do you decide the internal nasal wall to be addressed? Number one, how do you assess the need of addressing the internal nasal wall? By means of computerized tomography, CT scan, by means of nasal endoscopy, by means of symptomatology. How do you, define what cases need to be addressed for the internal nasal wall deformity? Because nasal obstruction is a common phenomena. We don't know which patient needs the external nasal wall correction, which patient needs the internal nasal wall correction. Can you elaborate? You have been doing so much in this field for years together. You have been so experienced. Give us a, whatever you say is a dictum for us in brief, please.
So, as you well know, Satish, the problem with nasal obstruction, it's a very subjective thing. We sometimes look inside the nose and you can drive a bus up there and the patient complains of nasal obstruction. And sometimes you can't even see the airway and they say, I have no breathing difficulties at all. So it's a very subjective thing. I think the most important thing about internal nasal valve obstruction is having the concept of knowing about it. A lot of people see mucosal disease, a lot of people see septal disease, but they don't understand internal nasal valve. So objectively, are there any tests you can do? I don't use a CT scan. I don't think that helps. I think CTs are very, very subject to, sometimes you see internal nasal valve things, but the nasal cycle has been shown to influence that. So I don't find CT scans helpful. You can do the so-called Cottle's maneuver or Cottle's test, where you can ask the patient, or you pull the cheek laterally, thereby opening up the area between the upper lateral cartilage and the septum. But it's a very subjective test again, and it's a very crude test, because even if you do it on a patient who doesn't have nasal valve obstruction, they feel an improvement. So if you're going to do anything, I do the modified Cottle's test, where you put a little cotton bud or even like a wax hook. You can just use like a little wax hook into the nose and just lateralize the upper lateral cartilage and see if that gives them a significant improvement in the airway. But for me, I think the best way of knowing about internal nasal valve obstruction is the patient tells you. They will often tell you, doc, I go to sleep with my hand over the edge of the only way I can get to sleep is I hold my hand across when I'm trying to sleep, because that's the only way I can get air in. That's an absolute classical sign for internal nasal valve obstruction. And some people use the strips, those strips that the sports people use, which pull the upper lateral across the, we call them breathe right strips in the UK. I'm sure you get them in India too. And again, that's very sort of almost diagnostic of this. But it's a difficult problem because, you know, we all know nasal obstruction isn't just about valve. It isn't just about structure. It's all about mucosa as well. And you know, there's lots of controversies even about treating it. So Sunil is doing a beautiful demonstration here of how to put spreader grafts in. But, you know, spreader grafts aren't the be all and end all. And you may need other techniques, although spreader grafts is one way of dealing with this. So Sunil, show us the spreader grafts now and show us where you're putting them in.
So the important thing,
Dr. Sunil is going to demonstrate the spreader graft and the spreader flaps.
So the most important thing that first you know that what is the indication of the spreader graft and what is the ideal length and breadth of the spreader graft and what material is suitable for the spreader graft. So we usually need the spreader graft to the patency, to maintain the patency of the internal nasal wall. So the spreader graft ideally length is 25 millimeter to 30 millimeter long, and it's depend on the situation to situation. Ideally, the length from when you put the spreader graft from the under surface of the nasal bone to till the antenasal spine. But if you need,
Sunil, for the junior colleague, you said from the nasal bone to the nasal septum. So, what is the exact placement of the spreader graft in relation to nasal bone? How much deep it should go, and how much inferiorly it should project from the nasal septum?
The upper end of this spreader graft is just like beveled, and that should be under. That should be under the nasal bone. Okay, and the lower ideally is the length till the level of the anterior-septal angle. But if you want to lengthening the nose and you need the more support, then you increase the length as a extended spreader graft.
Like extended septal?
Yeah, that is the extended spreader graft. That is the extended spreader graft.
Okay.
So,
can it work like septal extension graft?
Can it work like septal extension graft? But whenever you separate the upper lateral and septum, that it means it's my message to my junior colleagues that it's not necessary in every case you use the spreader graft, because the Indian scenario we have a very good support on the dorsum. So in every case, because Rollin Daniel, a very standard book, and so many Western literature mention that whenever you separate the upper lateral and septum, then you use always the spreader graft. It's not necessary. There are certain indications, like if you have the open roof deformity, if you have a deviated nasal dome, if you have a asymmetrical aesthetic lines. So it's depend on the situation to situation. Either you use the bilateral, either you use the unilateral. Sometimes if your mid vault is deviated, so on that time, the concave side you use the thicker spreader graft rather than the convex side. So after the mention the ideally length of we measure it and we put it pocket between the upper lateral and the septum. So it's depend on you. Either you can fix the 5 structures simultaneous, but for my beginners rhinoplasty surgeon, I advise that first you fix the 3 structure, then it easy for you, and then simultaneous you this both side of the lateral cartilage, so that easy. So first you fix the septum and both side of the spreader. Once you fix this one, then you fix the both side of the upper lateral cartilage. That is the easy method.
Sandeep,
yes,
what makes you thinking of using the spreader graft in the situation of upper lateral cartilage collapse? Number 1. Secondly, to broaden the dorsum. Number 3, we want just clarity. Number 3, when you other things you use for the upper nasal wall collapse. Is it the only thing you do for the upper lateral wall collapse?
No. it's one step potentially. So by what we know is by widening using spreader grafts, you should get an exponential increase as you widen that angle of the internal nasal valve. You get an exponential increase in airflow using Bernoulli's principle of looking through wind tunnels. You get the same effect of opening that up, and you get a huge amount of airflow. However, in practice, I think spreader grafts alone, if you're just doing it for function, are probably inadequate. So I tend to use a upper lateral cartilage spanning suture, and that's difficult. That's difficult for me to be able to show that. I'm not. Sunil, do you know Stephen Park's upper lateral cartilage spanning suture? Did I teach you that?
Yes.
Sunil?
So, can I ask one more thing? When you need the spreader graft and the septal extension graft together,
Mm-hmm.
can you use the spreader graft as a whole?
As a what? Sorry?
Can you use a spreader graft as an extended septal graft as well?
Extended.
Can you use the spreader
We
graft?
can use the spreader graft as a extended spreader graft. We can
Yes,
suture
certainly
with
you
the-
can use that. You actually in Jaipur, you've seen Jung do that, Satish.
Yeah, you can use an extended spreader graft, but you've got to have a good reason for using an extended spreader graft. There's just no point just putting an extended spreader graft in. You're normally using extended spreader grafts to attach to a septal extension graft to stabilize a septal extension graft. So by themselves, it's a bit pointless doing that.
Yeah.
Now, just to point out what Sunil is doing here, the important thing is you need to have a 5-layer closure here. So you need to, your suture has to go through the upper lateral cartilage on one side, through the spreader graft, through the septum, through the spreader graft, through the upper lateral cartilage on the other side. And so a 5-layer closure here is the critical thing. Now, often people try and do this all in one go clinically, and it's difficult. So what I tend to do is a 3-layer closure, i.e. put the upper lateral cartilage, put the spreader graft onto the caudal septal, onto the dorsal septal region, suture that in place first, and then separately do this 5-layer closure. Because otherwise what you tend to do is you can end up moving the spreader graft in the wrong position, and it doesn't sit where it ought to sit. There's also some, again, probably less important in thick skin patients, but there's some thought that one of the problems it can be an advantage or a problem. If you've got an inverted V, it's certainly an advantage. But one of the things you inevitably do by putting spreader grafts is create a little extra width of the mid-third.
You can see how Sunil has sutured 5 things together.
Yeah, but I think what I'm trying to say is you can, it's fine, but I think, personally, I think it's better to do 3 and then do the 5.
Sandeep, there is one more question from audience for both you and Ashim. What material you are using? Sunil is using PDS. Anything different and why?
I use PDS.
I also use PDS because I had problems with Prolene in the past of suture coming out, sticking through, and a little bit of granulation around it. So I've stopped using Prolene. I use PDS.
I use 4 frequently.
Yeah, I use PDS. I tend to use 5 or 4 or 5 PDS.
So we show the spreader graft. It's basically horizontal mattress sutures from this to this, and then 2 or 3 suture fixation is enough for the spreader graft. So I just open it again and I show the spreader flap. So basically the spreader flap is just you modify the width of the mid vault. So first for the spreader flap, you just separate the perichondrium and then 2 or 3 millimeter after, in case of hump removal, if you have the axis upper lateral cartilage, then you fold it little bit inside. So this is the spreader flap. You fold it and suture it. Suture dena. Give me the suture. Yeah, hold it. Dr. Pawan, how frequently you use the spreader flap, and what is specific indication for the flap rather than spreader graft, sir?
So, Sunil, as you know, I prefer spreader grafts. I think it's a very secure way of dealing with it. I do use spreader flaps really mainly when we are cartilage depleted. So one of the advantages of using a spreader flap is that you don't need a separate piece of septal cartilage for the spreader graft, and you can just reuse what you have. I think it's fine if you aren't really looking for functional improvement. I don't think spreader flaps give significant functional improvement. But if you just want to use it as a support to avoid to avoid a inverted V deformity, then I think a spreader flap works fine. I think the problem with them just using that alone for function is they don't work so well. So it really depends. I think if I've got cartilage, I prefer to use a spreader graft. If I'm cartilage depleted, I'll tend to use a spreader flap. Guys, I just have to say, I'm about to start a clinic. I apologize. This has gone on a little longer than I expected it to do, and I have a clinic starting imminently. So I might dip in and out, and I apologize if you can't hear me or see me. I'm going to be in between patients, but I will try and dip in and out if that's okay.
Yeah, I'd also request you to excuse me because I also have my OPD to attend to.
Yeah.
So.
Yeah.
Satish, are you there?
So now we finish this mid-vault modifications technique. Now we come on the tip modifications. How can after the spreader graft, we put this upper lateral cartilage. We elevate this perichondrium, and then we rotate inside the axis 1 or 2 millimeter part of this spreader flap. This is the spreader flap. So we can modify the width of the mid-vault also by the spreader flap.
Okay, so Sunil, Sunil, I'm going to have to
both things by spreader flap and the spreader graft.
We are missing you this year.
Yeah, I'm so sorry.
We are missing you in Jaipur.
I know.
We have to promise her very soon going to be coming to Jaipur.
Listen, as soon as we can get rid of this damn virus, I'll be on the next plane. But until we get there, unfortunately, like everyone else, I am bound to being in the UK. But I promise I'll be there as soon as I can get onto a plane and be safe to do so. So, guys, I'm going to have to switch off at this point. I'm so sorry, Sunil. It's a pleasure in seeing you again and doing great work. It's lovely to see you're using the same techniques that I've been coming and teaching for a while. And Ashim, always a pleasure to have you here, buddy. And so as I say, I'll try and switch back in again if I get a chance. But forgive me because I've got a pretty busy clinic coming up now.
You know how much I am enjoying this moment.
Okay.
Ashim has done hundreds of rhinoplasty for us, for our VIP patients. But this is the first opportunity I've been, able to ask him questions and questions.
Okay.
Pleasure is mine, Satish.
I want to kill him with questions and questions.
Pleasure is mine, Satish. Unfortunately, I have to start my OPD too. I've been trying to call you. You're not picking up your phone.
So
I know.
So we come on the tip. Tip is the most difficult aspect in the rhinoplasty. So the foundation of the tip, how can we modify this, depend on anatomy, aesthetics, and analysis of the tip. So if we revise the anatomy of the LR cartilage, then this is the medial crus. So the foot plate part of the medial crus is this one. and this is the columella part of the medial crus, and then this is the lobular part of the middle crus, and this is the domal part of the intermediate crus, and this is the lateral crus. Of this lateral crus is the widest part of the LR cartilage. So it gives the maximum volume to the tip.
Can you show us, Sunil?
Yeah.
I'm a beginner. Can you show us the transdermal, interdermal, all kind of sutures?
Yeah.
So,
Yeah.
okay. All that. By the way, can you show us how to project the tip?
Yeah.
And how to reduce the tip?
Yeah.
All maneuvers.
Yeah. We show some systematically.
Yeah,
so
all maneuvers we want to see.
So there is some tip characteristics like the volume of the tip that basically is dependent on this LR cartilage, this lateral crus of the LR cartilage. And another is the definition of the tip that basically is dependent on the angulation of this dome. Okay. And another is the width of the tip that basically depend on the width, the distance of between these two dome. And another is the projection. So the projection, basically the projection is a distance by which the nose tip project from the face. So this is the projection, and another is the rotation. So rotation either on the upward direction or in the downward direction. So these all are the tip characteristics. So
can you show us in brief?
Yeah.
Quickly.
So if we want to reduce the
techniques.
Yeah, first I just reduce the cephalic trimming.
Okay.
For the decrease the volume of the tip.
Okay, to show the cephalic and of the lower cartilage trimming.
Yeah.
Huh?
For the cephalic trimming, we just excite the cephalic.
How do you decide that this is required to be done?
Yeah, if the volume of the lateral crus is more than 8 to 10 millimeter, then we excise it. Or if the patient claim that the big volumetric.
So cephalic means how much of the cartilage you leave inferiorly?
Yeah, at least in Indian patient, we should preserve 6 to 8 millimeter.
And rest we can remove safely?
Yeah, we can remove, but at least 8 your 10 millimeter in thick case patient we should preserve.
That is a message that keeping 6 to 8 millimeters below, we can remove the cephalic part of the lower cartilage which is bulging.
Caesar.
Safely.
Yeah. So if you can use a infiltration in the vestibular mucosa also, and we excise the cephalic part of the lateral crus.
So can you hear me?
It decreases the volume of the lateral crus, and the lateral crus is the more malleable after the excision. And this is the good material for the tip defining graft also. So this is the cephalic trimming.
Santadeep, can you hear me? Are you online?
How much we remove, that is not important. The important thing that is the how we preserve. So this is the cephalic trimming. And now lateral crus dena more than the with la la. So for increased projections, we use the columella strut. The columella strut is ideally the length of the strut is around the 20 millimeter long. Yeah. This is the 20 millimeter long and 2 millimeter width and 1.5 thickness. And ideally, the warmer part of the septal cartilage is the best source for the this columella strut. So after the ideally dimension, we create a pocket on the antenasal spine, and we insert in this pocket, and we fix it by the needle. Put it. So you can fix by a 26 gauge needle. So by this columella strut, you can have the better tip stability, you can have the better support, and you make a unified tip. So for the fixation of this columella strut, either you can fix skin to skin or the submucosal. But if you fix the skin to skin, then sometimes the post-operative, the patient feel the knot. So it's a better you fix it subcutaneously. And the entry and the exit is the same. Two or three suture, that is enough for the fixation of the strut. Yeah. And there is some, you left some tissue.
How much you project and how much you ensure being sutured with the anternasal spine?
Yeah, there is no need to the fix with the antenasal spine. We should left, yeah, we should left 2 or 3 millimeter tissue above the antenasal spine to prevent clicking to the patient. Otherwise, the post-operative, the patient, there is a complaint.
Okay, any problem is suturing with the skin, both sides?
Post-operatively, later the patient actually feel that knot. So I think it's better if we suture it in subcutaneously. The cartilage is brittle.
You can feel the knot and
yeah. है ये टूट रहा है एक्चुअली में क्या है give me another one piece, give me another person, because the cartilage of this rib cartilage of this patient is the brittle. छोटा देना, give me small one, give me small one.
How much it should project about
नहीं ये नहीं काम आएगा ये बार.
Depending upon the requirement of the elevation. Tip elevation?
Yeah, by the tip projection there is other method, there is septal extension graft, there is.
For tip projection,
yeah,
if this columnar strut is useful?
Yeah, but if your caudal septum is not adequate and if you have not support of the caudal septum, in that case, for the better foundation, you have the septal extension graft is better.
Okay.
Then in that case, the septal extension.
Can work.
Yeah. This columella strut is good for the projections, but the patient sometimes feel the clicking sounds by this one.
So what he is showing is the columnar strut. He has already shown the spreader graft. He has already shown the value of the septal extension graft to project the nose. To reduce the nose, same way you have to reduce the septal extension, you have to trim the nasal septum.
Yeah.
The septal angle, isn't it?
If we need like the deprojections and the and we need the rotation, if we need the upward rotation, then we excise some part of the antiseptal angle area.
So Sunil, after this, can you show us the tip maneuvers, like
you
want to project the tip, you want to sharpen the tip, what all you can do, like intradermal, dermal suturing, whatever.
Yeah.
Yeah, inter and intradermal.
So I fix my strut with the 50 PDS. Cut it. So 2 or 3 suture is enough for the fixation of the strut. Now, the dome suture, there is 2 types of the dome suture. One is a dome creating suture or intradermal suture, or is a dome defining suture. So the suture from medial dome to lateral, basically it's a horizontal mattress suture. from the middle to the lateral, and again from the lateral to medial for increase the angulation of the dome. And the important thing, you put behind 2 or 3 millimeter the anterior margin, otherwise you create a tenting of the TP. Yeah, this is a dome creating suture. It's a dome creating suture to increase the definition of the dome. So it's a dome creating suture.
What is interdomal and intradomal?
So you
When
never
you need interdomal, when you need
interdomal
intradomal, and
interdomal suture, when we suture from this dome to this one for decrease the width of the tip.
Okay.
For the decrease the width of the tip. So you never confuse with the intradomal or interdomal. Interdomal, just like an intercity express, they connect the two cities. So interdomal connect the two dome.
Okay.
So you never confuse.
The site of the interdomal switch is also important.
Yes.
It has to be cephalic or caudal.
Yeah, definitely. If you add the more,
It should be cephalic.
yeah, it should be cephalic. Otherwise, there is a single point tip.
Sunil,
Yeah.
had you been needing a more tip projection,
Then
would you keep the columnar
Yeah.
strut more high
no,
up?
if you have a thick skin patient with
No,
graft,
would you keep the columnar strut more high up?
no.
If you
It
want
should
a
not-
more
it should
columnar,
not, it should not
more
above
tip
the dome
projection.
area. It should not above the dome area.
In
But
spite of you need a tip projection.
then you use the sealed graft. Sealed graft like this.
Can you show us the silk
Yeah,
graft?
yeah. Needle dena. This is the sealed graft. So if you need like the more projections and more support of the tip, then you use this sealed graft. So the sealed graft you put between upon the foot plate of the medial crus, and you fix it by a needle.
Okay, on the columella.
Yeah, you fix by like this one. That is the cap graft.
Okay, cap.
So this is the sealed graft. So the important thing in sealed graft, the vest,
Doesn't it affect the columella show?
yeah, it affect if this is more than 3 millimeter above the dome area, then it affect, or if the patient have a thin skin, in that case there is a visibility outside. So not more than 3 millimeter above the dome area. And if you need more than 3 millimeter the dome area, then you use some support behind the sealed graft, or you use a
But how do you
fascia.
control after this graph the columella show? It may increase.
May increase, definitely increase suture. So we suture it, it's a big size. So we suture it with the dome area on this side and on another side, because it's a tough cartilage of the costal cartilage. So it's a bigger
sealed
piece.
graft.
Yeah, it's a sealed graft. Graft.
This will improve the columella show as well as the tip.
Yeah. So we suture on this side, on this side.
This is for columella.
So you basically for good increased projections and good columella show, and just reduce the infra tip lobule hanging.
Okay. This will give a support to the infratip lobule.
Yeah.
Okay, that's a great concept that it is going to support
And-
to the infratip lobule.
And sometimes this lateral crus have the more deformity, like the normal orientation of this lateral crus is towards the lateral canthus. But sometimes if rather than the lateral canthus, it is the more cephalic towards the medial canthus, then that is the parenthesis deformity. So in that case, the patient need the correction, or sometimes this lateral crus have the paradoxically convex deformity. Usually this lateral crus is convex, but sometimes this lateral crus is concave like this one. So in that case, we separate it from the vestibular skin and then cut it and then flip it again. Like, give me seizure. Fine seizure. Give me the fine seizure. इसको नीचे वाली को पकड़ो. If you infiltrate, that is good. एक वो देना. एक. And if you use the support of this part of the external nasal wall collapse, then you use a lateral chloride strut graft. So one end of the strut is under the lateral crus and another is on the piriform aperture. So for give the more strength of this, yeah, so basically is the LR contour graft. And another is the lateral crura graft. So lateral crura strut graft and lateral crura graft, basically you put on this lateral crus, not underneath the lateral surface of the lateral crus. Give me. So, huh? Yeah. Yeah. You can use the rim graft sometimes if you need there is a weakness in the lateral wall of the external nasal wall. Then you may create a pocket for the rim graft. You create a pocket in this, and so it's a non-anatomical type graft. You put in the pocket for just for rim support. देना एक छोटा उसमें दूसरे वाले में. So you put in this LR rim graft. Huh? Yeah, that's so many. Yeah. Tooth forceps. So this is the LR rim graft. The length is around the 10 millimeter long, according to the need. So just give the support to this the LR rim. So this is the LR rim graft. Yeah, no need to the suture it. No need to the suture it. So I think this, this is all enough about the anatomy of surgical anatomy of the nose regarding the rhinoplasty. So it's my message to my junior colleagues, then whenever you do the correction of the abnormal anatomy, then you always respect the normal anatomy. You never disturb the normal anatomy whenever you correct the abnormal anatomy. So so basically the whenever you correct the abnormal anatomy, then always respect the normal anatomy. So these all about the tip sutures, but we always assess then what underlying deformity patient have before to start, and you make a operative plan. That is the good. And once you expose the entire nose, then you check what earlier diagnosis you have. That is the good habit, and the marking habit is also very good, because the anatomy is most important, and the aesthetic analysis of the nose is also important, because you have the normal anatomy, but that anatomy is not in normal parameters, and the dynamics of the anatomy, the dynamic factor is also important.
Yes. Very good, Sunil.
Thank you.
Can you show the osteotomy marks?
Yeah.
Under the skin now, or can you remove the skin and show the osteotomy marks?
Yeah. These are
actually we want to see where exactly the osteotomy site is. Once you remove the skin.
Yeah, actually, this is our nasal bone. We already demonstrated this once, but if you go more than above this intercanthal line, then you damage the medial canthal ligament, and you always go the high, low, high in manner. High, low, high. So it's depend on the case to case that which type of the osteotomy you need and what pattern you follow. What pattern you follow.
Yes, exactly. So, Sunil,
Yeah.
can you show beside this osteotomy,
Yeah.
if you need to put anything to increase the dorsum,
Yeah.
what all you can use?
Another important thing, if whenever you need the augmentation of the dorsum, then the important thing when you raise the flap of the dorsum, so if you want like the augmentation of the nose, then your dorsum pocket that should be adequate, not too much, otherwise you need a lot of augmenting material. That is the important message to my junior colleagues. And another important thing, whenever you put a graft on the dorsum, then the length of the graft from the radix to the anterior septal angle area, and you should fix it with a 40 suture, so there is a low chance of the displace. And suppose if your case have a lot of the augmentations, then in that case you use a integrated L strut. So in that case you make a slot on this lower end of the dorsum graft, and this slot fit in this your strut, so it make a good assembly. But if you rather than do this,
can I ask a question, sir?
Yeah, hello.
So Sudeep here. Sudeep बोल रहे हो सिस्टर से?
Sudeep, can you hear me?
हाँ जी सर. Yes sir, yes sir.
Sudeep, can you hear me?
Yes sir, yes sir.
Nice to have you, Sudeep. And for the audience, we have a very dynamic rhinoplasty surgeon with us now, Dr. Sudeep Munjal from Sirsa, Haryana. He's besides being a dedicated otologist, we all know his excellence. He's a dedicated rhinoplasty surgeon as well.
So we fix it.
Sunil is dissecting a fresh cadaver.
Okay.
He's showing a lot of maneuvers. We have a lot of questions. We have a lot of, controversies. He's now, putting a strut.
Yeah, integrated L strut.
Hello.
I
got confused. I thought surgery chal rahi hai, sir.
Can you see him?
Hello.
Yes, can you see him? Can you see the operating picture?
Yeah.
Sir,
Deep, can you see the operating picture?
So,
can you see the picture?
नहीं आ रही. So I think we should finish now. So I think is all about the.
Hello.
Hello, Sudeep, can you hear me? Sudeep, can you hear me?
He cannot hear. Na, he cannot.
Sudeep.
Yes, sir. We can hear you, sir. Satish, sir, I can hear you.
He can hear you. He can hear you.
Okay, is it Sudeep? Is it Sudeep whom I can hear?
Hello.
Is it Sudeep?
Satish, sir, can you hear me? We can hear you, sir.
Yes, I can. Can I hear Sudeep?
Sir, can you hear me? Satish, sir, can you hear me?
Yes.
Yeah, fine. I am Dinesh, sir. Doctor, can you talk with the Dr. Satish, sir?
Yeah, Dinesh.
Yeah. Is Dr. Sudeep Munjal there?
छोड़ो वो नहीं हो रहा.
डॉक्टर सुदीप सर, आवाज आ रही है?
I think वो नहीं बात करी ना. I think we should.
Sudeep sir, can you hear me? Sudeep sir. Sir, might be he got disconnected. You can continue, sir.
So I think Sudeep is not able to connect us, and we have already closed the time limit. And we are so grateful to Sunil for demonstrating his surgical skills.
सर मैं आ ही रहा हूँ.
Sudeep, can you hear me?
कैडेवर डिसाइड कर रहे हैं. कैडेवर में तो मैं क्या कंट्रीब्यूट करूंगा. हेड एंड थोड़ा सा.
नहीं वो दिनेश है. वो दिनेश.
Okay.
Thank you for keeping the patience.
Thank you all for joining us.
All.
And big thanks to Sunil and
thank you,
Satish sir, for making us, so wising. Hello. I'm really thankful to Sunil and Pradeep sir for making us more and more wiser. I'm really grateful to Dr. Santadeep and Dr. Ashim Desai for their expert comments. And obviously the big thanks to the audience for making this event successful. And unfortunately, I can't connect to Sudeep. Sudeep, who is a wonderful rhinoplasty surgeon from Haryana. Unfortunately, because of the network issues, we can't connect to him.
Yeah.
So now, having seen the basic steps of rhinoplasty with discussion on the pros and cons of the various techniques and pros and cons of the surgical aspect, I hope the discussion is never ending. And we can always, in our future webinars, we are going to involve Dr. Santadeep Pon, who has agreed. We are grateful to him to demonstrate us a live surgery from London.
Yeah.
Yes.
And Dr. Ashim Desai from Mumbai. We are very soon going to have a live surgical session from both of these. And more than that, I'm really grateful to Dr. Sunil Tawar for demonstrating us amazing anatomy, his efforts on showing the anatomy of the nose. And
thank you from my bottom of heart, from my mentor, and it's my privilege.
Our mentor is Pradeep sir. Without him, no event can be organized.
Yeah.
Pradeep sir is the man.
Keep enjoying, keep learning, keep enjoying and keep learning.
Thank you, the JNU.
Thank you all. And biggest thanks to the Jaipur National University for giving us opportunity to organize this cadaveric event. Big thanks to the principal, Mishra Saab, for organizing this event. And thank you so much for all your support and love and affection.
Thank you.
Thank you. Sudeep.
Yeah, Sunil, good to see you. Sunil?
Can you hear me? Sudeep.
Yeah, Sandeep. Sandeep, sir, can you hear us?
Yeah. Hi.
Yeah. So can you hear the Dr. Satish Jain, sir, also?
Yeah.
Yeah, just you can talk.
Sandeep sir, है ना?
Hi guys, I'm sorry I couldn't. I missed the last bit of it. And
thank you,
Sunil,
sir.
lovely
Thank
dissection.
you.
Well done.
इसको निकालना, इसको होल्ड करना. Thank you, Sandeep sir. Thank you.
No worries. Look forward to being in Jaipur soon.
Yeah, really, it's a good session. So, thank for my bottom of heart. Thank you, sir. So you.
No problem. We'll catch up soon,
So
Sunil. Good
yeah,
to see you.
now due to the time we wind up the dissections now.
Yeah. Okay, we'll catch up soon, Sunil. Take care.
Yes, sir.
Bye-bye.
Thank you, Dr. Sandeep, for joining us and giving us so much of information. Sparing your valuable time. I know your time is precious. You are a celebrity rhinoplasty surgeon, I know. Getting your 2 hours is much more than anything we can think of. Thank you.